If one has budget issues, then single chip system will suffice in knee arthroscopy. And if one has a multi-dimensional setup or one has laparoscopy also, then one can also opt for three chip system, which is a big investment initially, but it pays off in long run. The camera then attaches to the light source, and light source can be of xenon or LED, but usually nowadays we prefer LED because it has no heat issue. And the light source has fiber optic cable which causes refractions and it glows the issues, so it has to be coiled very carefully and has to be ETO sterilized. The fiber optic cable, the light source always faces the opposite direction of what one is viewing, and camera head and light source and camera system, these are better opted if one can afford to go for imported ones also. The next component comes in the scope. The scope can be of 30 degree, 70 degree and 0 degrees, but most commonly needed in knee scope is 30-degree scope. 4 mm 30-degree arthroscope is the most commonly one, and I would like to recommend you to go for the imported ones only. And there are many attachments that are provided with scope that can attach to various camera systems. So whenever you are making a purchase, try to get maximum attachments. The straight 0 degree viewing is not recommended because it narrows the vision, while when we use 30-degree scope, it increases the vision field of vision by 90 degrees. There are other accessory instruments which can be scissors, punches, graspers, knife, shaver, that one needs to sort out what one needs initially, and others can be procured from supplier of the implant. These instruments, some basic instruments should be available in one's own inventory. The probe is one of the basic instruments. It should have a rounded and blunt tip. Some Indian manufacturers have sharper tip, which can be a trouble. So probe is very important because you feel it as if you are using one's finger. The other instrument that one needs is a basket forceps or punch. Punch is useful in cutting the structures, and then it drops free within the joint. It can be straight one, hooked one, it can be up biter or down biting. So at least one or two probes, one or two punches one should have in his inventory. No, the other one is grasper or grasping forceps. Grasping forceps can be locking one or non-locking one, where the ratchet is locked and fixed, and in the other one you need to manually press it. It needs to retrieve the foreign loose bodies or synovial or meniscal flaps, and the jaws of the grasping forceps can be of single jawed or double action. These are some instruments that are optional, and only if you feel you can go for it, otherwise you can skip it. Now, shaving system is one of the main systems that one needs for arthroscopy. It consists of a handpiece and a core unit. The inner sheath functions as a cylindrical blade that spins and cuts the tissues, amputates it, and then it is sucked outside and collected. So shaver systems are of many suppliers. They can be from Smith Nephew, they can be from Carl stores. But if one is in the initial phases, one can go for Indian shaver systems also. Uh, Rest of the system, I would think one should invest on imported ones only. So there are electrofrequency, electrosurgical laser and radiofrequency instruments, and in the initial phases, it seems difficult to invest in them. However, if you are working in a corporate setup, you can get them installed. Because these cost too much if you are going for the imported ones. Instead of this, if initial days for simple ACL and meniscus, you may skip it because mostly they are not needed. However, you can have a jugaad because you can use underwater cautery of 400 kilowatt to uh, function somewhat, but you should be careful. It should be used only with glycine, and cautery can be used if you select the probes carefully. The probe should be insulated, and these probes need to be procured carefully with only specific vendors providing them. Now, arthroscopy instrument storage and care is also one of the issues. In initial days, some of the surgeons use formalin, which is not recommended, and one should go for ETO only. Leg holders is an accessory that new surgeons are opting for. However, I have not got leg holders, and I prefer lateral post, that I think most of the functions can be provided with a lateral post. This is my setup that I have. So I would like to share it. This is a shaver system. The shaver system is recruited from Mectronics, which is an Indian setup. It has 5000 RPM oscillating mode, and this is the light and camera unit. The light source is LED one, and it is from Carlis source. The camera system is single chip system, which is also from Carlis source. That it is telecam DAX. It is a very basic system, single chip, but I think most of the knee surgeries can be done. If you can afford, you can go for the higher ones also. These are the instruments and other things that I have. Uh, so these are shaver heads. This is the camera head, and it is from Carly stores. The camera head consists of two buttons which are for white balancing, and there is a focusing button. This is the fiber optic cable for light, and these are the probes. These are the grasper and punching forceps. I have up biter and down biter also. These are the tendon strippers. These are imported ones because I feel tendon strippers from Indian manufacturer are sharp at the tip, and they may cut the tendons for while harvesting. This is the camera arthroscope, which is also from Carl stores, and it is a 30-degree scope, 4 mm, and it suffices the vision because these lenses are fiber optic lenses. From these lenses from imported ones are very good. These have these attachments, and these attachments help you to when you're freelancing, you can attach it with other systems also. If the camera system is not from the same company, then these gives the attachment. You should also have obturator sheath and rotating sheath, which helps in attaching with the uh, scope and camera system. The obturator and sheath should be blunt. So when one sets up a arthroscopy practice, patience is needed because there is a long learning curve, and also there should be name and fame when patient come to you. So I would recommend those who are in post graduation that they should try to focus on scopy while post graduation. They should not focus it that when after I finish post graduation then I will learn. So you should learn within the college, then you should go and see or assist cases with seniors and also do some category courses. You should seek help and ask favors from your seniors and visit some centers. uh, I have visited many, and I am lucky to have help from all of you. And you should do some fellowship, maybe short term, long term, as per your desire and area of practice. Then you should, even in initial cases, or if the case is difficult one, you should get someone to assist, someone to give you opportunity, and you should have some place to work. You should start doing it first in some diagnostic cases or meniscectomy, though it may be tough, but in initial cases, I would recommend you to get help and give results, and then the patients will send patients to you. Thank you very much, and I wish you best of luck.
Excellent presentation from Dr. Harjit Singh. Now I call upon Dr. Sunit Rajshekhar for his presentation on diagnostic arthroscopy, developing an algorithm. Questions and answers will be at the last of this session. Sorry, Sunit is not available. The next, I would like to call Dr. Vinay Tantuve from Indore. He will speak on knee MRI, an essential guide.
Good morning, everybody. Good morning, Dr. Tapasvi. Thank you for providing opportunity in IS platform. And to begin with, after you have started the setup, as Dr. Harjok told us, we should focus on the MRI, because without MRI, it's very difficult to understand, as well as it's very difficult to make the patient understand that what is the problem going on. So this is a very basic talk to understand what kind of injuries we can find in the knee joint and how. So there should be a systemic approach. As the talk we have missed is the diagnostic round. So we developed a diagnostic round systematic approach so that we don't miss anything. So the similar systematic approach should be there in the in reading the knee joints MRI. There may be a different approach for different people, but you should have your own one. I follow the things. This is a website xrayhead.com. Here you can see interactive slides of the MRI in which you can learn the anatomy of knee joint, how it looks in the MRI. So in the coronal section, sagittal and axial, this is my sequence of seeing the MRI. And in the coronal section, we start from the inside out approach. So we look for the bone first, then the fluid, then the ligaments, menisci, and then the cartilage. So in the bone, we see from the medial to lateral, we identify that the medial femoral condyle and the lateral femoral condyle. You can see a medial collateral ligament. It's not working. So medial collateral ligament, you can see coming straight from medial femoral condyle to the medial tibial condyle side, and you can see the contour of the bone, osteophytes. You can see the patellar tendon. If any kind of marrow edema, contusions, or fracture, if present, they can easily be seen in this. Then, by seeing the contusion, you can identify what kind of pathology the patient can have and what kind of mechanism of injury possible in the patient. So there are typical pictures, typical placement of the edema or the location of the contusion. You can identify whether the injury is a pivot shift injury, which is commonly seen in the ACL, dashboard type of injury, which is commonly seen in the PCL tears, hyperextension injuries, clipping or the valgus stress injuries which are seen in the MCL tears, lateral patellar dislocation where you see the patella, medial facet of the patella involved along with the lateral femoral condyle, and the posterolateral corner injuries. So by seeing contusion itself, you can find out what kind of injury it may be, and what are the things which may come in other slides also. Then the fluid. After seeing the bone, you can see the fluid. Small amount of fluid is present in between, but it is better assessed in the axial images where the location of the fluid is very critical. Then the ligaments. You should proceed from the medial to the lateral. So we see the MCL. It is attached. It is uniform and full thickness bundle attached from the medial femoral condyle to the tibia. Then going from medial slightly, you can see the PCL, and in subsequent slides, you can see that the PCL is going down and is going attached to the tibia. Similarly, ACL attached onto the medial border of the lateral femoral condyle. You can see the attachment, and you can follow that thing, and you will find it is well attached. And in this image, you can see even the two bundles of the ACL. Then further laterally, you can see the lateral collateral ligament. Attachment of the lateral collateral ligament is higher one in the lateral femoral condyle, and you can trace it down. This is going, and it is going and getting attached to the tip of the fibula, and you can even see that it is going attaching with the biceps femoris tendon as a conjoint tendon. Further laterally, you see the biceps femoris getting attached to the fibula. Iliotibial bend laterally is seen in the anterior films, in the anterior sequences. You can see this thin line of streak going attached to the anterior lateral quarter of the tibia. Then in the meniscus, you can see a triangular dark structures. All meniscus appear black in all the images. You can see it is a triangular and sharp inside edge. Okay. The lateral side, this is the capsular attachment. If you find any kind of tear or signal changes here, you can label it grade 1, grade 2. But if the tear or the signal changes communicates to the articular surface, then only you say that is a meniscus tear, it's grade 3 or a complete tear. As you go posteriorly, you will find that the meniscus root is getting attached to the tibia. So this is very important thing to see all the sequences, how the meniscus from anterior is going posteriorly and is getting attached. Similarly, on the lateral side, lateral meniscus root attachment. Then the cartilage. You see the cartilages in between both the bones, but these sequences are more clear in the T2 images, where this fluid act as a contrast, and you can find out the separate cartilages very clearly. Then the sagittal images. Once you see the coronal image, then the sagittal images. In these sagittal images, the sequence we follow is the medial compartment first, then the intercondylar notch or the cruciates, then lateral compartment, and then going in front for extensor mechanism and the patellofemoral cartilage. So from the medial side, you can see the medial meniscus, anterior and posterior horn of the medial meniscus. And you can see that the medial meniscus posterior horn is coming slight anterior and getting attached as a root in the intercondylar region. Cartilage of the medial femoral condyle and the lateral tibial condyle, medial femoral and medial tibial condyle, you can appreciate well. There is small changes or fibrillation flake is seen in this femoral condyle cartilage. Then in the intercondylar notch, you see the PCL. In one or two sequences, you can see complete PCL getting attached. It's dark, it's broad, and it's very strong ligament. You can appreciate it. Then after PCL, you see the ACL. It is attached onto the lateral femoral condyle and to the tibia downwards. And the slope of the PCL is also very important. Slope of the ACL. So it is very steep, and the angle of the ACL to the tibial plateau is equal or greater to the Blumenstadt line. You can see it. If it is more horizontal, you can think of it is torn, especially from the femoral side. So when it turns to the femoral side, it can fall back and it will be more horizontal. Then the lateral compartment, lateral meniscus, you can see anterior in the posterior horn and cartilage of the lateral compartment. Further going laterally, you can see in a few good films that the lateral collateral ligament from the femur and the biceps femoris attachment to the head of the fibula. Then you see the extensor mechanism. You will see quadriceps tendon, patella, and the patellar tendon. And you see the patellofemoral cartilage also. And the findings of the coronal and sagittal planes are then confirmed and are seen well in the axial images. So axial images, we see the extensor mechanism first, patellofemoral joint, then the ligaments, and some other findings like Baker cyst, pes incidence, other. So from top to bottom, you will see first anteriorly is the quadriceps tendon, and then gradually you will find down is the patella, then patellofemoral cartilage. And then in other films, you can see the meniscus, medial and lateral meniscus. PCL is seen in the center film, the posteriorly. You can see the posteriorly collection of the fluid in the popliteal fossa. Also, the fluid can be seen in the pes region between the hamstring tendons. This is all for the basic of the knee MRI. Thank you very much.
Excellent talk, Dr. Vinay. Sunit, are you there somewhere? Sunit Rajshekar. Okay, so now I invite Dr. Sachin Tampaswi for his talk on clinical examination of the injured knee.
We'll start with the live clinical
Excellent. So I think the first thing is to establish a good rapport. बेटा आपका नाम क्या है? हाँ? खुशी. So खुशी मेरा नाम सचिन तपस्वी है. मैं आपका लेफ्ट नी एग्जामिन करने वाला हूँ. Okay. So खुशी couple of things जो आप देखेंगे. बेटा कैमरा जो है ना ऊपर दिखा दे. कैमरा ऑन यहाँ पे. सो खुशी आपका लेफ्ट नी है, करेक्ट. और इनका जो स्पोर्ट है, आपका स्पोर्ट है टाइक्वांडो. टाइक्वांडो में लीडिंग लेग कौन सा है आपका? लेफ्ट लेग. सो इनका लेफ्ट लेग इज अ लीडिंग लेग, करेक्ट. एंड बिकॉज इनका लेफ्ट लेग इनका लीडिंग लेग है, इस कारण बेटा ये कैमरा का फीड इसमें देखो. हाँ हाँ. सो इनका लेफ्ट लेग इनका लीडिंग लेग है, इस कारण इट इज वेरी इंपॉर्टेंट कि शी हैज टू हैव अ स्टेबल लेफ्ट नी. राइट. नेक्स्ट थिंग, आप कौन से लेवल पे खेलते हैं? State level. So she is a high energy or a high impact athlete, and she is going to be a pro, which means that your treatment plan has to be tailored in that particular aspect. Okay. Now खुशी में ये थोड़ा दोनों पैर ऊपर रखूंगा आपके, चलेगा? Excellent. यहाँ पर भी. हाँ. और आप हमारे लिए ना यहाँ पे खड़े हो जाएंगे 1 मिनट प्लीज. So we are going to make her stand here. I'm sure you'll be able to see a good demonstration when this thing. Okay. कैमरा को फेस कीजिएगा. एंड कैन यू पुल अप योर ट्राउजर्स दोनों ऊपर तक. वंडरफुल. दोनों साइड कीजिएगा. एक्सीलेंट. ओके. अब सीधे खड़े रहना है आपको. टोज पॉइंटिंग स्ट्रेट. ओके. सो व्हाट आर द थिंग्स दैट वी सी हियर नाउ? वी सी अ कपल ऑफ थिंग्स. द फर्स्ट इज ये कैसा लाना मन, ये निकाल देना. यूट्यूब वाला बाजू करना यार. हाँ. ओके. जूम आउट कर बेटा. जूम आउट कर. Zoom out, zoom out, zoom out, out. More, stop. Okay. So couple of things. Right leg goes straight completely and I see it hyper extends. So इनको जो है hyper extension है right side में. Left push back पूरा सीधा नहीं होता है. आप एक काम कीजिएगा. इसका आ रहा है क्या? हाँ. खुशी face them वहां पर. Good. Okay. बेटा zoom in कर. Zoom in यहाँ तक. बस stop. Okay. Push your right leg behind. You can see कि the right side goes into hyperextension. Push the left. Push the left. Left. So the left does not extend completely as much as the right. So she's starting off with an hyperextension in the knee. And when you treat such athletes who go into hyperextension is one of the major complaints that they will always come back to. And hyperextension attitude will predispose her to an ACL rupture. But if you don't give her back good decent extension or a few degrees of hyperextension, then again she may not be very happy with the outcomes. अभी खुशी आप सामने फेस करना प्लीज उनकी तरफ. Good. Right. So what else do I see? down, down, bas, stop, zoom out, thoda sa zoom out, out, stop. Okay. What else do we see here? We see on the left side, she has a hallux valgus, she has a bunion, and same on the right side as well. And stand on the right leg. Please lift your left leg up, Kushi ji. सीधे खड़े रहिए, ऊपर उठाइए, घुटने को ऊपर उठाइए, please. Good. So her foot pronates on the right side, and now on the left, it pronates on the left as well. So she's got foot pronation, she's got hyperextension. Okay. The next thing I want her to do is to look front, सामने की तरफ. You can keep your hands by the side. हाथ side में रखिए ऐसे आप. Okay, good. Stand on the right leg, lift your left leg up. And I'll just show you 1 second. आपको जो है, I want you to stand like this and bend down and come up. Good. And up again. One more time on the right side, and one more time, and up. Now on the left side, if it is possible, very unstable, up. One more time, very unstable, and up. So thank you. So what are the things that we've learned here? One is that she has got very poor stability in her hip joint on both sides. When she goes and does a single leg stance, she's buckling forwards and she's doing this. So if she's flexing forwards, that means that her hip extensors are weak. And this is something that we need to strengthen, because all of the instability is not just ligamentous, there's dynamic instability as well. So as a part of her prehab program, you want to concentrate on her hip extensors. And because she's going inwards, that means her hip abductors are weak and her hip internal rotators are tight. So that's the first prescription for her therapist, correct? That she has to have good hip extensors, good hip abductors, stretch out her hip rotators, and she will need some form of orthotic correction on her feet, because if she pronates, and with hyperextension, she is going to want to sort of buckle inwards and lead to problems. Kushi, please lie down. So I finished the first part of the assessment now, and now we'll go to the actual clinical exam. In the clinical exam, please lie down, Kushi. In the clinical exam, we are going to see both her knees. The first thing, always start by examining the opposite side first. That does two things. It will give the patient a sense of confidence. And second, you need to refer off what is normal to understand what is abnormal. So in our preoperative clinical exam, we knew that she is hyperextensile. So she's got about 20 degrees of hyperextension on the opposite side. It's always a good habit to quickly feel the pulse, check the range of motion. And while you're checking the range of motion, always try and observe if the patella is sitting properly or it is shifting out, so as to say, which can then suggest or understand whether there is any patellar instability that needs to be unmasked. Moving on to the left or the injured knee, first thing I'm going to do is to milk the suprapatellar pouch and see if there is an effusion. Of course, there's an effusion. She has a grade 1 effusion, if I can put it that way. So that's the first thing. Then again, very quickly, I am going to hold the patella and I'm going to try and move it side to side to check if there is normal patellar glide. A lot of people will get tightness in the patella and then this leads to problems. So again, you want to check that very quickly. So we've sorted out on a very quick clinical exam that apparently there is no patellofemoral problems or pathology here. Next, we come to a more specific focus towards the injury that she's got. On this side, I'm going to gently raise the heel to see if she has hyperextension. It goes to about 10 degrees on this side. And on the opposite side, it is far more. So she's lost a bit of extension or hyperextension, which makes me believe, or which brings me to the fact that she's not able to hyperextend because either she may be having a locked meniscus or she has that the stump of her ACL is flipped forwards, is in the intercondylar notch, and then that is not allowing her to hyperextend completely. Once you've sorted that out, you want to feel for any tenderness. So agar dard hua to bolna mujhe please aap. You want to check for the insertions of the collaterals on both sides. Correct. If that is fine, we move ahead, and then we test for her ACL by doing the Latchman test. So for the Latchman test, roll the leg. So try and keep her completely relaxed. Hold her femur in your hand. And as you can see, she's got a grade 3 Latchman, which can be elicited very easily. I suppose you are able to appreciate. Otherwise, I'll just go on the opposite side and do a quick Latchman so that you can see on the screen. This is not the ideal way to do it though. Kushi, loose shoulder, please. Yeah. Correct. No. Okay, so this is a grade 3 Latchman, which she has got. It has got a soft endpoint. Always important to compare this with the opposite side for two reasons. One is that there may be a physiologic laxity which you are missing out on, and you tend to over represent this particular knee pathology. Or second is that there may be a contralateral ACL tear as well, which is now very high on my thought process, because if you have an ACL rupture in a contact sportsman who is less than 18, especially in a female, then her risk of having a contralateral ACL rupture is about 18%. So you don't want to miss that out for sure. She doesn't have symptoms on the opposite side for now. I want to then gently ask her to bend her knee, pura pair mudiye aap, and I want to check dard ho raha hai? Huh? If she has got any pain or any form of discomfort while doing the same. So that's good. Next, we come to checking the collaterals. I'm going to do the pivot shift test last, because the pivot shift is probably the one that may give maximum discomfort. So to check the collaterals, I'm going to check it at full extension. I can see that there is some opening on the lateral side. Okay. Always compare that with the opposite side. So that's her physiologic laxity pattern. Very important. Then we're going to bring it to about 30 degrees and again do the same thing. I can feel there is a very soft end point when I'm doing a lateral opening. Dikh raha hai na beta? हाँ इकडे नाही ना या साइड नाही येईल का हाँ या साइड येतो का इकडे नाही ना हा तर Kushi, try and leave it loose. Okay, so now we can see that okay, so this is laxity at 30, and then I'm trying to see if she is lax at 90, which she isn't. Okay, again checking for the same thing. The next thing that we'll see now is that because there is some equal laxity at both 30 and 90 on the lateral side, I want to then move I want to then see if she has got any form of abnormal rotational instability. So for that, now I'm going to do her dial test. So I'm going to bring her knee to 90, look at her tibial condyles here, hold her ankle at the malleoli, and I'm going to rotate externally to see whether she has any abnormal rotation. So I'm doing an external rotation dial test. The anteromedial tibia is not popping out, and approximate dial test is around 30 degrees. You don't want to hold the foot and twist, because then you get movement in the ankle. You want to hold the heel, hold the malleoli, and then turn and have a look. So her external rotation on the right side is about 30 degrees. I'll do the same on the injured side now. And it is absolutely similar, correct? So she does not have any rotational component of her posterolateral corner or her posteromedial corner. What will constitute a positive dial test? If you have a side-to-side difference which is at least more than 20 or 30 degrees, that will constitute a positive dial test. And along with the dial test, it's not only the rotation that should change, but you should see either the fibula sagging posteriorly, which means that it's a posterolateral corner injury, or if it is a posterior, or if it is a anteromedial corner injury, you should see the anteromedial aspect of the tibia pop out, which will then tell you that it is an AMRI or an anteromedial rotatory instability, or you have a PLRI, which is a posterolateral rotatory instability. Okay. So we've looked at collaterals, we've looked at the basic palpation, we've looked at her range of motion, and now the next thing that we need to see is her PCL. So for her PCL, we're going to be doing a posterior drawer. Keep it relaxed at 90 degrees. The first thing that you want to do is that you want to feel the medial femoral condyle, and then there is a step. So as you run your finger down, you hit the medial tibial condyle, and then the medial tibial condyle is more, is placed slightly anterior to the contour of the MFC, which is why you have a step which we will always feel. If there's a PCL tear, you will have obliteration of that step, which is a grade 1 injury. And then as the PCL injury becomes further advanced, there is reversal of this step off. You want to hold your hand and give a posterior drawer. At the same time, always keep a finger and palpate whether this step off sign is lost, which will tell you whether there is a PCL injury. The anterior drawer test for diagnosis of an ACL is not used very often now, because essentially the sensitivity of the anterior drawer test to diagnose ACL rupture is not very significant. So if you want to do your diagnosis, you want to look at your Latchman and you want to look at your pivot. So for an anterior drawer, of course, you want to see and observe that yes, there is an abnormal anterior translation that we see here. You want to very quickly compare it with the opposite side. You want to ensure that her hamstrings are relaxed, which is why my hand is palpating her hamstrings. And you want to confirm that there is definite laxity on the left and not on the right side. There are variations of the anterior drawer which have been described, which include keeping the leg in external rotation and performing the anterior drawer. This can unmask any incidental anteromedial rotatory laxity, or keeping it in internal rotation and doing the same, which can unmask any form of ALRI or anterolateral rotatory instability. However, again, these are not very sensitive. The last thing that you want to check is our pivot shift. So the pivot shift is in two components. One is a valgus that you need to give, and the second is that you need to take the knee from a position of full extension to flexion, and you want to see how the anterolateral aspect of the tibia subluxes. Bageza, beta beta piche jo. Bas zoom nahi. कर 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 बस 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 ठीक है, zoom out कर, enough, बस okay, चल on, good. Okay, so for the pivot shift, first is to have her completely relaxed. I'm keeping my hand on her head of the fibula, and as you can you see the pivot shift happening there? Were you able to appreciate? See how the tibia subluxes? थोड़ा zoom in कर बेटा. Good. Okay, so I'm giving a valgus with my left hand, and with my right thumb I'm increasing the valgus. I'm बेटा सीधा रखना पे, last time करूँगा, and then as I bring it up, the tibia subluxus. So this is a pivot shift, which is a grade 2 pivot shift. So which means that she has injury to her anterolateral structures. Okay. So at the end of this clinical exam, we have a young girl who is into professional sport. Her sport is a high contact sport, which is Taekwondo. Her leading leg is her left leg. She has got a grade 3 ACL rupture. She's got hyperextension. She's got foot pronation. She's got a weak glute medius, a weak glute maximus, a tight hip rotator, and she has rotatory instability. So that concludes her clinical exam. Does anyone have any questions? So if so, we'll answer any questions related to clinical exam now. If not so, then we'll excuse her and we'll thank her for coming here. No questions? Yes? Biden, yeah, good question. Sorry, I missed that on out. So yes, I would be checking for her Biden score. So she does have hyperlaxity, which we looked at. She's got hyperextension of the thumbs. She's got hyperextension at the fingers. She's got hyperextension at the elbow, correct? And if you make her flex forward and try and touch down, she will be there. So she has a very high Biden index of roughly about 9 on 13 or 11 on 13. All right. Okay, we'll come to that. Anything pertinent to her clinical exam? Yes, sir. Yes, sir. Correct. Absolutely. Absolutely correct. Which is why the first step before doing a draw is to palpate and confirm that you have a normal physiologic step off. If you have lost the step off, as what Dr. Agarwal sir is saying, that the tibia is subluxed posteriorly, and what you're doing is you're bringing it back to neutral, which is then interpreted as an ACL tear, which is why the first should be your latchman, confirm the tear on your latchman, and then go to the drawer test to essentially look at your step off and confirm that there is no PCL, and then close it up by doing a pivot shift. Yes, sir. Good question. So if there is a PCL with a posterolateral corner injury, a prone position test is always very pathognomic. Here I used it in a supine position because there was no PCL tear, and just for everybody's sake, to get her into a prone and do all of that would have been a bit not very nice, which is why I didn't do it here. Correct. So joint line tenderness is more sensitive and more accurate for diagnosing a meniscus tear. A McMurray's test at times may be very painful. One, if there is a torn meniscus, and it is not very specific and sensitive for diagnosis of a meniscal pathology. So I don't do that too much now in my clinical practice. Only place where probably I would do it is if someone is complaining of a popping or a catching, and you're actually suspecting a hypermobile meniscus, which is when you would see that the McMurray's test gives a very loud pop or click.
Doing 30° and 90°.
Yes, it is important to check the dial test both at 30 and 90, because that tells you what is the severity of the injury of that knee. If you're looking at a posterolateral corner injury, the three structures which are involved on the posterolateral side are the lateral collateral ligament, you have the popliteofibular ligament, and you have the popliteus. So if there is increased dial test at 30, but not so much at 90, that means that your popliteus is spared. If there is a large dial test at both 30 and 90, it means that your popliteus, your popliteofibular ligament are blown out, and which is why then you need to tailor your reconstruction accordingly, and you have to take that into account. So if there are no further questions on clinical exam, we will ask Khushi to get up. We will thank her, and a big round of applause for Khushi. Thank you so much. Khushi legi.
Okay. So any other questions to any other faculties who have spoken? So we can start the second session.
I would like to call Dr. Harjot to receive his memento. I request Dr. Budhia sir to give the memento to Harjot. Thank you so much.
Well, the end of this session, I request Dr. Chabra to kindly welcome Dr. Manish Budhia. Chairperson. I'll request Dr. Sakle to please welcome Dr. Rai Chaudhary, our chairperson. Dr. Roy Chaudhary happens to be a faculty in a later session also. So with that, we conclude the first session. And now it's the time for inauguration of the ceremony, inaugural ceremony of the function. I request Dr. H.S. Agarwal, sir, to please escort Dr. Sachin Tapaswi, sir, to the dais and take his own seat also on the dais, please. I request Dr. Anshu Shekhar to kindly escort Dr. Sandeep Biraris to the dais. I request Dr. K.T. Kamble, President Chhattisgarh Orthopedic Association, to kindly escort Dr. Mukesh Ladda to the dais and take his own seat on the dais. I request Dr. Atim Kundu, Secretary, Raipur Orthopedic Association, to kindly escort Dr. Vinay Tantuve to the dais and take his own seat on the dais, please. I request Dr. Anshu Shekhar to kindly escort Dr. Shrikant Rajimwale, who is the Chief of Chhattisgarh Medical Council and is the observer for this workshop as well. Dr. Rajimwale on the dais, please. I request all the dignitaries to be please be seated. So this is a great occasion for the Chhattisgarh Orthopedic Association and Raipur Orthopedic Society as well. And we, the team Heritage, heartily welcome all the dignitaries on the dais. No academic function can be complete, or rather can be started without seeking the blessings of Goddess Saraswati. And to symbolize it, I request the dignitaries on the dais to kindly light the lamp, and which symbolizes that, O Lord, take us to the light of knowledge from the darkness of ignorance.
तुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव शुभकार्येषु सर्वदा। वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव शुभकार्येषु सर्वदा।
So it is our great privilege to welcome some of the finest dignitaries, finest arthroscopic surgeons from across India to be with us. And to welcome them, I first request Dr. K.T. Kamble, President Chhattisgarh Orthopedic Association, to please felicitate and welcome Dr. Sachin Tapasvi, sir. Thank you, sir. Thank you, Dr. Kamble. Thank you. I now request Dr. Atin Kundu, Secretary, Raipur Orthopedic Society, to kindly welcome Dr. Sandeep Biraris. Thank you, Dr. Kundu. I now request Brigadier Dr. H.S. Agrawal, sir, to kindly welcome Dr. Tantuve. Agrawal, sir, you have to present the plant as well. I now request the organizing secretary of the whole show, Dr. Anshu Shekhar, to please give a floral welcome to Dr. K.T. Kamble. Sorry. Dr. Mukesh Ladda. I'm so sorry. Dr. Mukesh Ladda. I request Dr. Suman Nag to kindly welcome Dr. K.T. Kamble and extend a floral welcome to him. I request Dr. Harjot to please extend a floral welcome to Dr. Rajim Wale. I request Dr. Roy Chaudhary to please welcome Dr. Atin Kundu, Secretary of Raipur Orthopedic Society. So that brings us to the end of the welcome procedure. And then I request now the President, Chhattisgarh Orthopedic Association, Dr. K.T. Kamble, to address the House with his kind words.
On behalf of Chhattisgarh Orthopedic Association, on the occasion of this Ias-One CME and workshop, I welcome all the dignitaries and the participants, distinguished guests, seniors. It's my privilege to honor you all, the dignitaries, the national faculties of arthroscopy, happening in Chhattisgarh for first time. And the entire effort of Dr. Anshu Shekhar has come lively today with the blessings of Dr. Tapaswi and all. When we are graduating and post-graduation under, we just could see an arthroscope and few of the procedures, and few of the CCSs were awarded for the arthroscopy. And as such, the word scope is, the arthroscopy finds out the different modalities for the future of orthopedics. If an arthroscopy is done properly, you find out what will be the best possible alternative for the patients. The dignitaries in the dais, they are all very well. They are performing with their experiences. Dr. Agarwal in Chhattisgarh as a brigadier retired from the army. And now the Ansu has joined, Dr. Sakale and Dr. Ghatge. Few of these surgeons are there practicing exclusive arthroscopy. So we are proud of them. And Narayana also hospital, the arthroscopists have working very hard. So one day, I think the Chhattisgarh Arthroscopic Society will have its own conference, and national and international faculty will participate. On this occasion, today, the 19th June, I must congratulate the Heritage Group of Hospital and the Chhattisgarh Arthropedic Association in association with the Indian Arthroscopy Society to have all of you with us today and share the knowledge of arthroscopy. Thank you very much.
Thank you, Dr. Kamble, for your kind words. I now request the observer of this conference, Dr. Rajim Wale, who happens to be the chief of Chhattisgarh Medical Council also, to speak few words and his thoughts.
Thank you, Dr. Sanjay Pandey. At the outset, I would like to thank IAS and Chhattisgarh Orthopedic Society and Raipur Orthopedic Society, and in particular, Dr. Sanjay Pandey and Heritage Group of Hospital for inviting me as an observer here in this function. I am not an orthopedician and not even the chief of medical council, but I'm the registrar of medical council. And I'm really feeling proud that I'm sitting with such great personalities here. Actually, I could observe just now the demonstration with a child. That was awesome. That was very fantastic. And although I'm not an orthopedician, but still I could gather some information from that. And I believe that in this CME and workshop, we all will be getting such information and such knowledge from the CME and workshop. I extend my best wishes for the success of this function. Thank you so much.
Thank you, Dr. Rajim Wale. And finally, I request the person whom we want to listen the most, Dr. Sachin Tapasri sir, to bless this conference with his kind words.
Respected office bearers of the Chhattisgarh Orthopedic Association, the Raipur Orthopedic Society, my seniors, friends, colleagues, my friends from the industry, and of course, the two main people behind this event, which is Shruti and Anshu. Thank you so much for having me over here. I was waiting for this day, to be very honest, when I could come to Raipur to see how this place is developing and improving, and it is very encouraging to see such fantastic work being done here. On behalf of the Indian Arthroscopy Society, of which I am the current president, couple of things which I feel I would like to share with all of you. First is that the Indian Arthroscopy Society has initiated this Ias-One drive, in which we plan to bring education for all to all of the small, I won't say smaller cities, but the ignored places within India. All these days, we would have all the big events happening at all the big metros. And I think places like these are the places where actually a lot of education needs to be brought into. We would want to nurture local talent and make them visible, since it is very important that the local talent gets showcased, and there should be a good exchange of ideas, not just at in Mumbai or Delhi or other places, but at local places as well. The Indian Arthroscopy Society also has started a lot of cadaveric courses, and we're in the process of adding 2 or 3 more centers, which will then provide more opportunities for all of us to interact and hone our skills further. Last but not the least, I will definitely encourage all of you people who are interested to come and take part with the various activities of our society, and then help it grow further in strength. At this juncture, I would not want to really come between all of us and the academic program which has been laid out for us. But 2 things I think which I would definitely like to sort of emphasize as I end my little talk here. First is that it's always important to grow as a team, because if you have a good solid team, which is what I see here today, I think it's not going to be very long before Raipur is recognized as an excellent place of learning on the map of India. Second, I feel that never stop sharing, because the more you share with your colleagues and you impart education and training, the better are you going to develop yourself as a physician, as a clinician, and at the same time, it will help sort of inculcate a new breed or a new troop of good clinicians and physicians, which will actually bring back a lot of work to you. So I thank all of you again for having me over here, respected office bearers and seniors and my dear friends. And we hope to see each other soon in the various educational events and academic events, which we will be conducting throughout the year and so on. Thank you so much.
Thank you, Dr. Tapasvi, sir. And after that, Dr. Sundar Rajan, who happens to be the secretary of IAP, who could not make it to this conference, has sent his recorded message. I'll request to kindly play his message. Dr. Sundar Rajan, Secretary, IAP.
Sachin Tapasi, Joint Secretary Sandeep, Organizing Secretary of this CME, Dr. Anshu Shekhar, and all the members of Raipur Orthopedic Society. I apologize for not being there due to personal reason, but it's a great program which is designed by Dr. Anshu Shekhar. Is going to be a great success. I wish for that. At the same time, as the IAS Secretary, I want all of you become member of Indian Arthroscopy Society. If you are not, please visit IAS website and become a member online. It is very easy. Just you can fill the form and upload your certificate. So you can learn from lot of teaching materials in the IAS website. And this is the 4th program by Ias-One. And this is a CME with live surgeries, demonstrations, and the dictated lectures. All the programs are very, very successful. At the same time, I want all of you to come to Coimbatore to attend the mega event of annual meeting of Indian Arthroscopy Society, which we didn't have for the last 2 years because of the pandemic. I'm sure that all of you will have a great time in Coimbatore because it's a great program. You can see the program. I think they might have distributed the brochures today. And I request all of you to come visit Coimbatore. That's why I put the background of Coimbatore mountains. You can go around, and also you have a lot of tourist places like Ooty, Valparai, Kodaikanal, like that. And I'm sure that you're going to have a great time in Coimbatore at September 15, 16, 17. I wish all of you to have a great time today for this program. At the same time, I'm waiting here to host you in September 15, 16, 17. Thank you very much.
Virtually, we thank Dr. Sundararajan for his kind words. And now finally, though I know the words will not be enough to express the gratitude and the sentiments that Dr. Anshu Shekhar has for all the dignitaries on the dais, especially his mentor for Dr. Sachin Tapaswi sir. But for formal vote of thanks, I invite Dr. Anshu Shekhar, the organizing secretary of this workshop.
Thank you very much, sir. The intention when I thought of starting this initiative was basically to spread education, and my entire outlook was maybe if we can replicate a little part of what my guru and mentor does at Pune, the Pune knee course. So this is a small attempt. I'm sorry if there has been any fumbles as we go through the day. This is our first event of this sort. We'll try to make it better this time. Big thanks to all the faculty who've come from outside, Tapaswi sir, Birare sir, Mukesh Ladda sir, and Vinay Tantwe sir. To the regional faculty, all of you, thank you very much. All of you accepted my invite to contribute to the scientific content. A very big thank you to all the seniors of the Raipur orthopedic community, Khemka sir, Chhabra sir, Jain sir, Punendu Saxena sir, Joshi sir. Of course, Pandey sir has been like a rock behind me. Thank you very much. A big thank you to the industry without whom this would not have been possible. Mytech Johnson & Johnson has taken most of the load, but we have pharma, we have 3 of them, and they were extremely helpful, and they have helped with the organization of this event. So a big thank you. I cannot express in words my gratitude, and hope you have a great day as we progress with the talks and the live surgery as well. Thank you very much.
Thank you all the dignitaries on the dais, and I request them to take their seats in the hall, and we can proceed to the next scientific session. For the next scientific session, I invite Dr. Sachin Tapaswi sir and Dr. Suman Nag to kindly chair the session. I request the chairpersons to see to it that the time allotted for each presentation is about 10 minutes. Dr. Tapaswi sir and Dr. Suman Nag, please take over. Thank you.
So our next session is the meniscus session. The first speaker is Dr. Mukesh Ladda. So he is going to speak on classification, identification of meniscus tear. Dr. Mukesh Ladda.
Good morning, everyone. Would like to thank Anshu and the whole Chhattisgarh orthopedics team for inviting me and share my knowledge and learn from all of you. So my topic is classification of meniscal tear and how you identify them on MRI as well as on arthroscopy. Next, किधर से होगा? Yeah. No, it's not. Hi, come through. Yeah, so we all know that meniscus, as we understood the structure which was neglected in the past, is how important that structure is in the prevention of mainly the osteoarthritis of the knee meniscus plays a very important role. These are basically two semilunar cartilages between the tibia and the femur, attached anterior and posteriorly on the tibial attachments, and the whole periphery is with the capsular attachment. So we all know the functions. Next slide. So it's load transmission, load bearing, shock absorption. Next, the most important is it's a chondroprotective, because meniscectomy leads to osteoarthritis, is very well proven in literature. And next, please. So if it's lateral compartment and the amount of meniscus you remove is more, radial tears, root tears, they reduces the hoof stresses, and that leads to early degeneration and osteoarthritis. So how you classify the meniscal tear? So based on blood supply and zone, you classify them as red zone, red-white zone, and white-white zone. So red zone is zone 1, red-white is zone 2, and white-white is zone 3 tear. So that how you correlate with the MRI now. So if you have a bucket handle tear, each and every orthopedic surgeon should able to read MRI on his own. Don't rely on radiologist report. So if you have a something picture like this, in the sagittal view, you should usually see a black meniscus, but it's empty. That means you should pick in your mind that where the meniscus has gone. And even on the coronal, the meniscus is not seen on the far extreme lateral, but you can see it's rolled up in the intercondylar notch. And the same thing you can see, and the same thing you can see here, that it's intact in the posterior aspect, it's torn completely, and the intact on the anterior aspect, and it's a classical bucket handle lateral meniscus tear, which you can correlate very well with the MRI. And then you need to do repair of such red zone meniscal tear. I'm sorry for that. So next is O'Connor classification, which basically gives the classification on tear pattern. And this is we usually use in our daily practice: bucket handle, root tear, longitudinal, horizontal, peak tear, parrot beak tear, and radial tear. Now let's see how we can correlate it with the other findings. So again, what lateral meniscus tear. It's like a total meniscectomy in presence of meniscus. Here I did a repair with suture anchor technique because it's quite easy to repair that in anterior aspect of the knee. Another classification of meniscal tear is given by Isakos, because O'Connor classification takes into consideration only the pattern of the tear. It doesn't take into consideration the quality of the meniscus, the length of meniscal tear, the location, and other things. So this Isakos classification is in-depth classification of meniscal tear, which takes into consideration the tear depth, location, the radial location, the tear pattern, the quality of meniscal tissue, and the tear length in millimeters. You should know this because all this will help you to plan your management, whether you want to do any sort of repair or you want to do any sort of meniscectomy. So as per Isakos classification, this is a complex type of tear with some bad tissue quality in the zone 3, but it's almost red zone tear in the posterior aspect with double horizontal component, some radial component also. So in such patients, try to remove the unstable part in the zone 3, that is in white zone, and whatever is visible in red zone, try to repair them whenever it's possible. Now again, another classification for meniscal tear is a ramp lesion, which we all know. Whenever you have a explosive pivot, suspect either ramp lesion or root tears or anterolateral instability along with ACL. A good classification by Tornat has been given in arthroscopy techniques, where they have described 5 types of ramp lesion. This is basically meniscotibial lesions, tear in the medial meniscus. So type 1, it's only the meniscotibial tear. So these ramp lesions are usually missed on MRI. So whenever you are doing arthroscopy ACL, always make it a point that you enter into the posterior medial compartment through your Gilchrist view, take your 18 number spinal needle and try to poke the posterior medial capsule, and you will be able to see a ramp lesions, which is type 1 only meniscotibial. Sometimes you may able to see a type 2 where you have meniscotibial but a full thickness into the posterior capsule and red zone. Sometimes you may have a double tear like type 5 where you have a red zone tear as well as you have a ramp tear posteriorly. So identify the meniscal tears well on MRI. A surgeon must able to read MRI on its own. Identify the tear pattern on MRI where using O'Connor classification, because tissue quality may be little tough to identify on MRI. Ramp lesion, very difficult to get on MRI. So always make it a point to go into the posterior medial compartment and try to see the ramp area. Isakos classification is useful in decision making. Always search into that dark area, especially into the posterior medial corner of the knee, which is little tough to open. Search for the tears there, and meniscus repair should be the priority. Thank you.
Thank you so much. Excellent presentation, Dr. Ladda. Our next speaker is Dr. Harsal. He is going to speak on non-surgical management of meniscus tear.
Very good afternoon, good morning to respected chairpersons, respected senior faculties and delegate friends. So my topic is on non-surgical management of meniscal tears. So meniscal tear are the common soft tissue injuries. Traumatic meniscal tears mostly occurs in young active males due to sport injuries, and degenerative tears more commonly occurs in the patient and is mostly associated with the osteoarthritis. Degenerative meniscal tear can be both risk factor for the knee osteoarthritis and as a sign of disease also. Both meniscal injury and meniscectomy have high risk of knee osteoarthritis because of increase into the contact stress, decrease into the joint stability, decrease the shock absorption mechanism, etc. So all of us are aware that meniscus are formed by the type 1 or type 3 collagens, which are arranged in a circumferential and radial. Fibers are arranged circumferentially, radially, and they use a hoop stresses which prevents the extrusion and thus tear to the meniscus. This is the important part. Because of the typical vascularity of the meniscus, it is difficult to get healing into the meniscus. Mostly as per the Miller and Warner classification, it has divided the meniscus into 3 zones. The red, which is the outermost and peripheral zone, which has good healing potential. Red-white, which is the middle zone, which is comparatively better healing potential. And white, which is the innermost zone, which has a very poor vascularity and poor healing potential. The mechanism of injury, all of us aware, is the turning and twisting of the loaded joint, which will lead to tear of the meniscus, and patient present to us with pain, locking, sensation of giving away, effusion, atrophy of the muscles, recurrent disability, clicks, snaps, or catches. So this is the important classification as discussed by Dr. Mukesh sir, given by Ias-One, which is based on MRI and which helps us to plan our treatment, whether to go for conservative treatment, whether to operate the patient. So it is based on the tear depth, location or width of the tear, radial inclination, whether the tear is central to the popliteus hiatus or not, tear pattern, horizontal, longitudinal flap, complete complex tear, whether it is bucket handle tear, what is the quality of meniscal tissue, whether it is a degenerative, non-degenerative or undetermined, and what is the tear length in millimeters. So depending upon that, we can decide whether to opt for the conservative treatment or operative treatment. So this is an important paper given by British Association of Surgeons for knee, and they had included the meniscal target MRI, and depending upon that, we can able to decide whether to go for operative treatment or non-operative treatment. So whenever we get a patient with MRI, there are some gradings of the meniscal tear which are helpful to decide whether what to operate or not. So grade 1 is the intrameniscal hyperintensity signal. It is maybe because of the myxoid degeneration and can be treated with conservative treatment. Grade 2 is a line inside the meniscus which is not communicating to either of the surface, tibial or femoral surface. So we can think of conservative treatment. Grade 3 lesions are the lesions in which the meniscal line is communicating with the surface and may need operative treatment if there are associated lesions are there. So these are some of the important tear patterns. So long horizontal tear, long or longitudinal tear, then radial tears, then ramp lesion, it is a posterior meniscocapsular avulsion. So if these findings are there on the MRI, and if the patient is having other associated meniscal lesions, then we have to think of operative treatment, not of conservative management. Then bucket handle tear, which needs a operative intervention like double BCL sign, double anterior horn sign, and absent bow sign. Root tears are there. If on MRI the root tears are visible, then again we have to think of surgical intervention. So indications for non-operative treatment are mostly the degenerative meniscal tear, partial thickness longitudinal tear, small tears, patient having minimal injury without injury to the other important ligaments like cruciate and collaterals, no locking symptoms, minimal swelling, able to bear weight, and full range of movements is present. So degenerative meniscus tears should be looked upon as a wrinkles with age and should be treated accordingly. And now it has been very well established fact that degenerative meniscal tear we can deal with this patient very well with the conservative line of management, and arthroscopic partial meniscectomy or other intervention may lead to arthritis. So we can manage those patients conservative also. Non-surgical management includes physical therapy, orthobiologics like platelet-rich plasma, stem cells, growth factors, mechanical techniques like mechanical abrasion, mechanical neovascularization by trephination with the help of needle that we can do with ultrasonic guidance also. So non-surgical management, to start with physical therapy, it is of mostly we can complete it in 3 phases: acute phase, recovery phase, and functional phase. Acute phase, the goals are reduction in pain and swelling, protection of the anatomical injury site, and restoration of the muscle strength. For reduction of pain and swelling, we can get it by relative rest, cryotherapy, foot and elevation, NSAIDs, and electrical stimulations. To protect the anatomical injury site, we can use the functional hinge brace, knee of row range of movement restriction braces. We can ask the patient to use crutches for initial stages, and then gradually we can proceed further. We can start the patient with some strengthening exercises like hip abduction, hip extension exercises, isometric strengthening exercises for quadriceps and hamstring. Second phase is the recovery phase of management, which usually is the longest phase of rehabilitation. In this, our goal is to improve the muscle strength, achieving normal muscle balance, correction of the biomechanical deficit, proprioception training, and initiation of gradual sport-specific activity. It includes the therapeutic intervention like USG therapy, superficial heat. We have to start the stretching exercises of hamstring, quadriceps, muscles, then hip flexor, hip adductors, and other calf elevators, hip abduction exercises on loops, etc. So gradually we have to shift the patient on further stage. Then proprioception is the most important one. Proprioception, balance training, balancing on a single leg while catching or throwing, balancing with eyes closed. So we have to start the patient on this type of physical therapies further. Then gradually functional phase management, which includes increase in power and endurance and return to sports. So functional strengthening exercises attempting to match the demand of the sports is necessary. So criteria to return the sports will absence of effusion, full range of movements, normal quadriceps and hamstring strength, normal hip external rotators, good proprioception, and functional exercises performed without any difficulty. At that time, in case of acute tears, which we have managed conservatively, we can ask the patient to resume to sport. That is usually after 8 to 10 weeks post-injury. Now for degenerative meniscal tears, this is a systemic review and meta-analysis, which includes degenerative meniscal tear, and it concluded that partial meniscectomy is not superior to non-operative treatment, that is lower extremity strengthening exercises. So degenerative meniscal tear can be very well dealt with the help of lower extremity strengthening exercises. Orthobiologics in meniscal tear. This is a paper by Malanga et al. They concluded that physical therapy is the first line in acute and chronic tears. Physical therapy performs better in elderly complex tears with underlying osteoarthritis. Orthobiologics like PRP, mesenchymal stem cell have shown promise in augmenting surgical repair or as a standalone treatments. Although research for their use in meniscal tear management is limited, and one more debate is that whether to give this orthobiologics intra-articularly or intrameniscal. This is one more prospective double-blinded randomized controlled trial in which they had included chronic horizontal meniscal tear, in which they had divided it into two groups. One group is percutaneous trephination plus PRP, and other one is just percutaneous trephination, in which they had, with the help of USG, they had done the percutaneous trephination and thus opened the vascular channels into the meniscus. And they concluded that PRP with trephination for meniscal shows significant rate of meniscal healing and survival. So we can think of this on this line also. So conservative treatment is for degenerative meniscal tears, small stable peripheral tears, low demand patient plus and minus with or without osteoarthritis, patient with minimal injury, without injury to other ligaments and no locking. Patient must be informed that any tear in the meniscus may not heal despite of the period of immobilization and physiotherapy. If the symptoms recur, surgical repair or removal of the damaged meniscus may be necessary. So to conclude, non-operative treatment should be considered in degenerative meniscal tear and highly selected traumatic patient. Role of orthobiologics is evolving and may cause a shift in coming decades. Proper patient counseling is mandatory, and proper documentation of long-term treatment outcomes is necessary. Thank you for your patience.
Thank you so much, Harshal, for this excellent talk. Maybe please call upon the next speaker, Dr. J. Roy Chaudhary, and he'll be speaking on how should we perform and when should we perform a meniscectomy.
So before, with the permission of the chair, before we proceed, Ajay, you got it. So thank you. Sorry. Actually, Dr. Ladda had misplaced his iPhone over there, so it was just a thing. Thank you so much. I'm sorry for interruption.
Respected chairperson and dear colleagues. There are 2 pointers here, I am right. So this being a tricky and controversial topic, and probably 1 year down the line, this talk will not be relevant because meniscal repairs are coming up in a big way and meniscectomy is going down. So when are we doing partial meniscectomy? So whenever we are saying meniscectomy, it's always partial, never total meniscectomy. And when are we doing it? As a procedure which is commonly performed for a degenerative traumatic as a method of pain relief. So partial meniscectomy can typically be performed in older age group patients also, where the meniscus has degenerated but without much significant osteoarthritis and when they are symptomatic. Partial meniscectomy of traumatic meniscus can also be considered only when it is only applicable when there is a complex tear or tears with high degree of degeneration, flap tears or non-reducible bucket handle tears. But again, I'm telling that most of these indications are also going away. You have to repair whenever it is possible. So discoid meniscus is one of the symptoms, one of the criteria where meniscectomy is only the preferred method of choice as an arthroscopy, and where we are preserving the stable peripheral rim, which has been successful clinical trials. Determining which patient will benefit from partial meniscectomy is a contribution of understanding the anatomy and clinical outcomes. So we are talking about the white zone. So partial meniscectomy in the white zone is to be done, but I have gone through so many papers now while reading about this topic. They are repairing the white zone as well and claiming about 50% success rate. So again, this thing is pretty evolving and meniscectomy word might go away. When there are mechanical symptoms like clicking, popping or locking sensations during ambulations, but only when there is intermittent effusion with pain. So that is the time we are considering partial meniscectomies. When a trial of conservative treatment has failed, so when not to do it, repairable tear pattern in vascular zone, partial meniscectomy is not to be considered. So indication of partial meniscectomy is in acute or chronic irreparable meniscal tears causing recurrent symptoms and significant functional limitation, although an adequate non-operative treatment is performed for more than 3 months. So how we do it? We require these posts, a lateral leg holder for medial meniscectomy, or if you have a counter, we can give both sides traction for medial and lateral side in a leg holder. Basic arthroscopy instruments are required, that a grasper, meniscal biter, and a shaver. The portals we use are the inframedial and infralateral, and a transpatellar portal can also be used. This transpatellar portal can be used to grasp the meniscus while we are cutting the meniscus from anterior and posterior parts. This is the viewing portal and working portal. What it says is, whenever we are doing, let's say, the posterior part of the meniscus, we have to look from the opposite side, that is the lateral side, and work from the same side. And if we are in the anterior or middle part, we have to look from the same side, work from the opposite. It depends on the angles, and you can keep on changing the angles as and when required. Probe is our finger inside the joint. You have to probe it properly and see the tear pattern before performing a meniscectomy. If it is repairable pattern, you have to go ahead with the repairs. Shaver is used to broadly smooth out the meniscal rim while simultaneously removing pieces of meniscal tissue from the joint. Otherwise, they will lead to synovitis in the later stages. This is a picture where you can do the meniscectomy, and they are showing that you have to cut the proximal part, posterior part first instead of the proximal part. Otherwise, it might go flip posteriorly while you are removing it from the anterior side first. Care should be taken to minimize damage to the cartilage of femur and tibia with camera or other instruments. So partial meniscectomy, medial meniscectomy, you can see a small flap tear. As I told you before, the probe has to be used and seen a small radial with flap tear, not extending to the red zone. It is only in the white zone. After having carefully examined it, when you are sure enough that it requires a meniscectomy, then you go ahead with your meniscal biter forceps and take out pieces. How do you take out the pieces? Is to create a very smooth, balanced rim so as to give the meniscus a proper outline where it can distribute the forces properly. How much to remove? As little as possible. You can use the shaver as well as the biter alternatively. And just see how little you can remove and then complete the procedure. And can give a C-shaped meniscus in the end of the surgery without giving much damage to the cartilage of either side of the bones. So the take-home message will be: consider partial meniscectomy in symptomatic patients with irreparable meniscus when conservative trial has failed. Use an accessory portal if needed. Preserve as much as possible. Leave a contoured, balanced, stable peripheral rim finally. And suction is to be used to remove any morselized meniscal fragments which might cause synovitis later on. Thank you very much.
Thank you so much. We'll now call upon Dr. Ias Agarwal to give his presentation, which is going to be an overview of all meniscus repair techniques.
Respected chairpersons, my colleague, today I shall be speaking on the meniscus repair techniques. I will very briefly touch upon the history, anatomy, and functions. Most of it is covered by my previous speaker. However, I will just tell it very saliently. When I passed out my orthopedics in 1985, I had no access to the MRI and to the arthroscope. And these were the knives which I used to do a small orthotomy and take out the meniscus. And the meniscus was considered to be the seat of the problem. Today we know that the meniscus is a critically important structure which reduces and minimizes the contact pressure across the joint by providing maximum contact surface. This has already been discussed that the meniscus, the outer periphery is vascularized and only inner 1/3 is white zone. And this is the natural history of the tear which progress to the larger tear if they are not addressed to. So coming to the meniscus repair technique, we have got various methods. The inside out, where we pass needles loaded with the suture, and they are passed from the inside the knee and they are retrieved by a safety incision outside. And outside in, where we have got two needles, one has got a snare loop and another in outside in, we have got two needles. One has got a snare loop and another one is a straight needle, in which we load a suture and that suture is passed to the snare and both the needles are pulled and snare is pulled. The repair is complete. And all inside by various fixator device. Various companies have various names like True Span, Fast Fix, and so on and so forth. And then hybrid technique. All the arthroscopists use hybrid technique where all kinds of methods are combined. And this is a different region, the anterior 1/3, middle 1/3, and posterior 1/3. In anterior 1/3, the outside in is very popular, and middle 1/3, the inside out, and posterior 1/3, because there is a proximity of the neurovascular structure, we use all inside. But this is just a kind of a the procedure the expert arthroscopist can maneuver in the way he wants. I want to tell you that the repair of the meniscus requires a fair deal of time. It may take as much as the ACL reconstruction, and repair of the red tear, the success rate is around more than 90%. And repair of red white zone is about 80%. The sound knowledge of safety incision is very important. You should learn how to make the safety incision from the master. The inside repair is exceedingly successful in certain cases. We should always try to preserve the meniscus because the loss of meniscus is synonymous to the arthritis. What are the factors governing the success of the repair? What is the age of the patient? How chronic is the tear? What is the quality of meniscus tissue? What kind of tear is the patient is having? How expertly the repair is done? What kind of suture configuration we are using? How we are spacing the sutures? And number of the suture used? What are the augmentation technique used? Whether we use the fibrin clot or not? And another game changer is the concomitant ACL reconstruction. If you do the ACL reconstruction of the meniscus repair, the repair is highly successful. These are the very basic and essential steps of the repair. You have to very clearly evaluate the tear. What is the extent of tear? Where all the meniscus is torn? You have to trim the ragged edges. You have to rasp and prepare the meniscus bed for this to receive the sutures. And in case you are doing the all inside in the middle and posterior 1/3, you have to make accessory safety incisions. And vertical sutures are best because the meniscus has got a circumferential fibers. That repair strength is the best. And when you are tying the sutures, each suture you tie under the arthroscopic vision. You should not over tighten the meniscus. Here you see in the video, there is a large bucket handle tear. And with the probe, we are trying to ascertain what is the anterior extent, what is the posterior extent. And in the second, you see we are rasping the meniscus. And after the rasping the meniscus, we have turned off the suction of the shaver and we are gently trimming the meniscus. So these are the very essential steps of the preparation of the meniscus before the repair. So inside out technique, which I used very oftenly. I use inside out and outside in. I hardly use fast fix or the devices because I am very confident in doing inside out even in the posterior part of the meniscus. And in acute tear, the minimum preparation is required. In chronic tear, all those steps which are shown in the video has to be done. And you have to make a posterior incision, safety incision in posteromedial or posterolateral side. And this description is there in all the text. And basically you have to push a Henning spoon, which is between the gastrocnemius head and the posterior capsule. And needles, we have got a single lumen cannula and double lumen cannula, which are angled. So you can avoid the posterior neurovascular structure. So these are the various safety incisions they are described in text, but they have to be mastered by doing a kind of apprenticeship, how the expert arthroscopists make the safety incisions. So what are the advantage of the inside out? When you push the cannula with the needle tip there, the reduction is immediately achieved. And you can apply all multiple punctures in the meniscus, rasping, which I showed in a video, and you must push. If you can do fibrin clot, Dr. Sachin does the PRP, he uses the PRP in his meniscus repair and BMSE. I push the fibrin clot. So these are the various test book description of how to make the fibrin clot. Basically, you have to draw peripheral blood, stir with the glass syringe, then wash with the saline, and then make it to the shape, and through the arthroscope, you can push at the site of repair that enhances healing. So at the bottom line, what I want to say that every arthroscopist who is doing arthroscopy for any other indication, he should be fully armed for the meniscus repair. Whenever you're doing arthroscopy, you should have every device. You should have a meniscus scorpion, you should have the fast fix, you are whatever, you should have the cannula, you should have the inside out needle, you should be in full knowledge of safety incisions, you should have Henning spoon, you should not do arthroscopy without meniscus repair. If you do not do the meniscus repair, then something greatly is amiss. And this patient might do a very good job on the ligament or some other structures to have the arthritis. So the meniscus repair, you must try and do it. Thank you.
Thank you, Agarwal sir. Excellent presentation. Now the meniscus session is finished. So the house is open for question and answer session.
Any questions from all of you?
Hello, check.
Yes,
One,
first
two,
question,
three.
yes.
Hello, check. Hello. Hello, check. 1, 2, 3, check.
When you are doing the medial side, you have to always pie crust. If you do not do pie crust, you are doing something seriously wrong. You will scuff the articular cartilage. You will your shavers, your camera, either you are likely to break your camera, you are likely to scuff. So you have to do medial pie crusting if you want to see the whole extent of meniscus, and if you have to pass the suture securely and see how your suture configuration is falling. So medial pie crusting, absolute yes for doing the medial sided repair.
Any more questions? Question to Mukesh.
Huh?
About looking at the MR classification and then taking it down when you go ahead into surgical treatment. What would you say would be the reliability of your MR scan to diagnose a meniscus tear properly? One. Second, does the quality of the MR scan matter? Third, on the basis of your MR scan, can you understand or predict that this is a repairable tear or not?
The first question, with the recent advent of 1.5 and 3 Tesla MRIs, and even they have 3D MRIs nowadays. So meniscus tear can be very well picked up on MRIs, provided you have a good musculoskeletal radiologist, or you know how to see in all the 3 sections, coronal and sagittal, about the meniscal tear. So I'll say the specificity of MRI is really very high, except in some ramp lesions where it's very difficult to pick up. Secondly, on MRI tears, we can easily identify the type of the tear. Regarding repair, yes, if it's in the quality of MRI view, tissue, meniscal tissue on MRI can be picked up very well, because if it's a horizontal and age-related old age patient, you know that's a degenerative tear, not amenable for repair. But if it's a young chap with some traumatic injury, you can see whether it's in the red zone or red-white zone. So you can easily pick up the tissue quality, as well as you can pre-operatively decide whether you are able to repair it or not. Sir, up to 1 year, there will be significant signal changes of your needle, of your threads, or whatever implants you are using. So up to 1 year, MRI will be very difficult to pick up whether it is re-tear or not, unless and until patient is quite significant, say even after 3 months of time. If he still feels joint line tenderness, he is having still pain, but you need to differentiate that with your MCL pie crusting, which also takes some time to heal. So I think it's more on clinical, and if you want to do MRI, minimum 9 months to 1 year after repair.
I'll just add to that. The problem happens if you have someone a radiologist who is not trained to read a post-operative MRI, and they will come back and report it as a meniscus tear, and then that patient will come and sit on your head. So for you to understand and realize on imaging that the meniscus tear has healed, it will take at least 18 months. The only positive sign which can say it is a re-tear is if there is displaced meniscal tissue at the site of the repair. Otherwise, I think I will agree with him that post-operative MR imaging for a repaired meniscus is absolutely worthless for the first 18 months. I will not prescribe it. I will look at it, because if you have some form of meniscus resection, which is the next question to Harshal. Where is he? Harshal, yeah, which is the next question to Harshal, is that many times, when you do a meniscus resection, and he discussed about non-surgical treatment of meniscal tears, you can unnecessary or unindicated resection of a degenerative meniscus may lead to sudden bone marrow edema. So that is what you can pick up. And I'd like a comment on that, because you mentioned which tears you should not repair. So can you let us know why you should not repair them?
Degenerative and complex tears which are not associated with other meniscal lesions. And on MRI, if we found that there are no other meniscal lesion, not a long tear, then we can manage it conservatively. But we have to counsel at the same time the patient that if it is not, he is not getting relief, if there is frequent swelling, frequent catching up, then he may need repair or excision of the partners.
A question for you. You discussed about meniscectomy. So what is the practical tip that you would like to give us, especially when we are looking at a tight lateral compartment, and our instruments, like for the medial compartment, very well standardized now that we do medial pie crusting. But you get that 1 in 10 patient in whom the lateral compartment is tight. You are doing a figure of 4. Somebody is pressing the thigh, somebody is lifting the heel, but still you don't get adequate exposure. What is your trick for that, please?
So when we are talking about isolated lateral meniscus without any ACL tear, with an ACL tear, I do not think there will be any kind of problem with that. But in isolated, the person who is helping you out, because you are holding both the things, he has to give a good amount of figure of 4. And your direction of your portals, whatever the instruments are going. So you might find it pretty difficult to do a meniscectomy. I feel it that way.
Sir, I have a question. So Raipur is a generally low budget practice. If we are to do a meniscus repair, it is definitely better that we fall back on inside out repair instead of opting for all inside devices, which are pretty expensive. For doing inside out repairs, what is your recommended suture? Does it matter in terms of outcome? Does it matter in terms of healing rates? For example, you have ultra high molecular weight sutures, you have things like orthocord, then there are Europeans who use even Prolene, some people use Vicryl.
In fact, I am a very strong proponent of the inside out and outside in. So inside out, I use 20 fiber wire that is loaded in the needle, and the local one costs only 2,000 rupees, and you can use 6-7. Like one fast fix will come for the rupees 20,000. In 10 or 15,000, you are done with. Only thing you have to be very careful about the posterior neurovascular structure. You have to know your anatomy well. You should know how to make the safety incisions and how to place your retractor. In your assistant have to be very good. I mean, when to pass the needle and how to catch the needle, and I mean, if he is missing the needle and it is seen inside the Henning spoon, and then there can be a problem. So I don't think the needle tracks are very small. and you can do really a wonderful repair, and those repair does not fail with the I mean the devices which are loaded with the implant, like all inside devices. Many time I mean I'm not able to deploy. Sometime when you are piercing the capsule and then you are pulling, the implant does not deploy, and sometimes the implant is pulled into the joint. So those kinds of problem are there. You have to be very expert in deploying them. So it has got a learning curve also, deploying those all inside device. So therefore, I use it very, I mean, when it is a near the root tier, lateral meniscus root tier, and where I am hard pressed, then only I will use this kind of devices. Otherwise, most of the time I am able to manage with the inside out.
I'll just add to that on his take of what sort of suture. I think if you're using inside out, look at the suture very carefully. If it is very harsh, it is going to cause something like a cheese cutter effect, and it is going to lead to secondary tears. So try and use a soft suture, which will probably get absorbed eventually over a period of 6, 9, or 12 months. That will be my preference. Yes, sir. Yeah. Correct. Yeah. Yeah. So yeah. Yeah, I agree with you.
Yeah, success. In fact, you have to do a re-arthroscopy, for which if the meniscus is healed, no patient will agree to it. If he has got a problem, then only he will let you his knee scoped by you. So successful repair is generally by clinical symptoms. Like if you have done meniscus repair with ACL, patient will be generally happy within 3 or 4 months. And in case he has got some kind of locking, catching, popping, it means the meniscus is not healing.
It starts from the age of the patient, the duration of the injury, the MRI findings, and then how good repair you do. And definitely it will be more of a clinical assessment post-operatively than MRI findings. How pain-free the patient is, no joint line tenderness after few months doing all activities and back to his original level.
Last question for Agarwal sir. If you find both the meniscus are torn, lateral and medial meniscus, which is your preference for repair first, and why?
The lateral side of the knee is a convex articulation, and therefore the role of lateral meniscus is much bigger than the medial meniscus. However, we cannot lose the site of medial meniscus. If both are torn, we both should be repaired. But if the preference goes, we should repair the lateral meniscus because it is convex articulation.
Thank you. With this, we end this session.
It was really a very healthy discussion session, and I think the house must be benefited a lot by this. I request our chairpersons to please be there for a while, and I request Dr. Tapasvi sir to please give a memento to the local faculty, Dr. Harshal Sakle and Dr. H.S. Agarwal. Dr. H.S. Agarwal, sir. I would now request Dr. Chavda, sir, to please welcome our chairpersons, Dr. Tapasvi, sir, and Dr. Suman Nag. With that, we come to this the end of this session. Scheduled is a coffee break, but due to paucity of time, I request the delegates to go and have your coffee and come back. We switch on to our third session, which will be on anterior cruciate ligament.
For the next session, I'd like to call Dr. Vinay Tantue and Dr. Rai Chaudhary to chair the person. Acha.
So there is a slight change. You can have your coffee. Organizing secretary says that we should break after 2 sessions for a coffee break. So let us say 5 minutes coffee break.
Hey. Hey.
हे येत आहे का रे?
Check. Hello, mic testing. Bug.
ऐक ना त्याला काय म्हणा मिक्सर वाल्याला ईपीचा ऑडिओ दे म्हणा स्पीकर मध्ये. चेक. हॅलो माईक टेस्टिंग. येतोय ना?
माझा येत आहे क्लिअर.
माझा बघ येतोय बरोबर.
हा येत आहे पण ब्लर हे तर
माईकवर बोल.
स्पीड येत आहे.
हॅलो. चेक.
तिकडून वाढव आवाज थोडा.
माझी लेवल वाढू का?
हा वाढव.
जास्त वाढू मग तिकडे पुंग्या वाजतील. एक मिनिट थांब. चेक. हॅलो.
हॅलो.
माझा जो ऑक्स घेतला ना त्याचा ऑक्स
थोडा कमी येत आहे लेवल ऑक्स वाढवू नये.
ईपीचा ऑक्स कट केला का त्यांनी?
नाही नाही आता बघ माझा क्लिअर येत आहे का?
तुझा येतोय ओके.
क्लियर नहीं आ रहा है इसका आवाज.
हेलो.
का
चेक टेस्ट. हेलो माइक टेस्टिंग.
हेड से
चेक
उधर
टेस्ट.
से उधर से
हेलो.
हॉस्पिटल
हेलो.
क्लियर आया नहीं चाहिए ना. हेलो क्लियर नहीं है.
हेलो माइक टेस्टिंग. चेक 1 2 3 4 5 6.
येता क्लियर. थोड़ा थोड़ा तिकडून आवाज वाढवून दे.
Shake. Hello.
हॅलो.
बोलो माझा आवाज चेक कर फक्त.
मेरा माझा येत आहे का? सिट्टी मारता
वाढतो काय?
माझ्याकडून.
अरे तुझ्या सिटी कुठे वाजते?
बघ आता.
ऐक ना बाबा मी काय बोलतोय. मी बोललो तिकडे मी इकडे ऑक्स वाढवायला लागलो ना तुला माझा आवाज द्यायला.
हा
तर तुमच्याकडे सिट्टी वाजताय कधी?
नाही नाही तू माझ्याकडे नाही वाजताय.
हे भाई
आता वाजताय.
एक मिनिट चालू ठेव. 2 मिनिट ना.
ये क्या है? हेलो. ये देख क्लिक किया तो ये देख गेन बढ़ाऊं थोड़ा. सिट्टी मारे ना.
May I have your attention, please? We can start our next session.
Start
And the persons who are
Hello.
standing in the coffee station may please take their coffee cups and come back to their seats. We are soon going to start our next session.
हॅलो. हॅलो. विकास चेक कर. हॅलो विकास.
हा चेक केलं. येत आहे क्लिअर आता.
ओके ना.
हा येत आहे. अच्छा है क्या? देख
कॅमेरा ओके दिसतोय.
काय म्हटलं का?
कॅमेरा ओके का? कॅमेरा
हो हो
ठीक आहे. माझ्याकडे तसं एकच कॅमेरा चालू ठेवलाय. ठीक आहे झालं
कॅमेरा
बोलू ना आता.
थोड़ा कमी कर लेवल यहाँ से कम कर उधर का. बोल बोल.
हेलो चेक 1 2 3 माइक
ठीक है
टेस्ट.
ठीक
चेक.
है.
I request everybody to come to their respective seats, please. If they are having their coffee, they can bring their coffee cups here and have their coffee here. And I request the chairpersons, Dr. Vinay Tantuve and Dr. Roy Chaudhary, to please proceed on to conduct this session on anterior cruciate ligament. I again request the persons who are standing on the coffee station to please take their coffee cups and come back to their respective seats, please.
Hello, everyone in that corner. Please come, bring your coffees over here.
So now I request Dr. Anand Joshi, sir, for his talk on anatomy of the ACL.
Right. So today we are about what? Since David Dandy did his first ACL arthroscopically in 1980, we are about 42 years down the line, right? And in this journey of 42 years, we still seem to be talking the same things over and over again. You go in a meeting for hip arthroplasty, they will rarely discuss the anatomy of the hip. But that's because our understanding of the ACL as a structure and the need of intervention is improving with time. So our understanding of anatomy has also changed, right? So I had the opportunity to go to Professor Frederick Fu's lab when he proposed the double bundle concept. And some of these pictures are from his collection. These are, this is how the anatomy looks, the ACL looks in a child, infant, adult, and more mature people, which means it changes its appearance throughout life. It shows these changes on the MRI too. If you see, this is the skeletal image of Lucy, which is a humanoid from about 3.2 million years ago, was found in Addis Ababa, and a modern human being. The lateral intercondylar ridge is almost at the same level, and the structures posteriorly are of the same shape. So anatomically, we haven't changed much, but our understanding has changed. Hence, anatomy becomes important. The ACL is a ligament which starts from the tibia, goes to the posterior aspect of the lateral condyle of the femur, and looks nice and shining with fibrillar pattern. A broken ACL smiles at you through the notch and provides you enough telltale signs about where to operate from. What are your landmarks? When you're doing arthroscopy, your landmarks do change in terms of when you flex your knee to 90 degrees. So it's important to note that as you are putting your scope deeper down, you're going posteriorly, right? The femoral footprint is completely behind the lateral intercondylar ridge. This is the much infamous residence ridge as described by Clancy. It continues with the posterior cortex, and most of your center of ACL is behind there. It is almost at the level of the posterior articular cartilage level, about 2.5 centimeters behind. So when you drill your tunnel, you want to save a 2.5 mm wall posteriorly. So your tunnel is located on the basis of the size of your graft and its location, whether you are doing an inside out or an outside in. That's where we want to be. That's where it seems anatomically the ACL produces best kinematics for the knee. And you get this varied jigs on which you can measure the posterior cortex you want to leave. The ribbon concept came in about 2016. This was brought in by the Imperial College and the Polish group, where they said that the ACL is not a two-bundle structure. It's a ribbon which weaves itself and changes its direction as you bend the knee and flex the knee. It is very thin in the middle. It's very thin in the middle, but it's like a trumpet when it inserts on the femur and the tibia. Biomechanical studies have now shown that the ideal position for your femoral tunnel is up and back over there, where it optimizes all the ideal positions, which consist of isometric, direct reduction, direct insertion, anatomical, low intention, and anatomic, right? The tibial footprint, on the other hand, is bigger than the femoral footprint. It's nearly 1/5 of the size bigger than the femur. It is well correlated to the anterior root of the lateral meniscus. Yeah, and is almost a semilunar shape. There is nothing beyond the transverse ligament in the front. So you are aiming for your lateral attachment, and then the center is just a bit medial and posterior to it. We used to measure it from the PCL in the past days, but now we know that if there's abnormal translation of the tibia on the femur, then you may lose that landmark, and sometimes the PCL is not even is injured too. Right, and if you look at the alignment, the anterior intermeniscal ligament is in the front, followed by the ACL footprint, and then the PCL. We must remember that the ACL footprint occupies an area close to the anterior root of the lateral meniscus. Hence, while putting in your wires, be careful that we are not harming the lateral meniscus in any way. It's a very important structure. We have discussed about it just now. So that's your pin where you want ideally to be. On the shin, you want to be about 1.5 to 2 centimeters behind the medial aspect of the tibial tuberosity. The MRIs do show how a graft matures over a period of time. So the initial 4-strand cords will show almost a dark signal as good as the original ACL. Then as the cells get cleared up and it matures, about a year's time, it reproduces a normal ACL signal. And that could be a good time for you to convincingly say that your ACL has really been revascularized and ligamentized. Remember, the ACL ghost is the best way to find your footprint. If it is there, preserve it to an extent where it can lead you to the landmarks. Right. There's another collection. If you look at all these ACLs of different animals, they all go on the back side of the lateral condyle. So there is nothing for the ACL. There is no space for it in the front of the notch. It has to go behind the notch. And as we say, the art is nothing but imitation of the nature. So if we are able to reproduce the anatomy, you would recreate the function too. That is the hope. But if we look critically at all the outcomes of ACL in the long run, historically, we have had about 30 to 40% not doing well in the long run, and we still are there. So the jury is out. Maybe in the future, with better biological methods and better rehab, we may be able to improve on those results. I think that's all I have. Many thanks for giving me a good listen. Many thanks to Anshu and all the organizers, Sanjay and the team. I hope you all are having a wonderful day and see you later. Thank you.
Thank you, Dr. Anand. May I please invite Dr. Sandeep for his talk, preparing the patient for an ACL reconstruction. We'll take all the questions at the end of the session.
Good afternoon, respected chairpersons and dear colleagues. I'll be talking on preparing the knee for an ACL reconstruction. So when any athlete or sports person sustains a knee injury, so what are the mechanisms they are involved? So what happens after the knee injury? First response is a swelling, which leads to joint effusion. And then once joint starts swelling up, then automatically quadriceps starts shutting out because of the nerve innervation. And then there is a loss of range of motion, and it is knee becomes more and more stiff and tight because of the guarding, and patient's gait and normal walking pattern is affected. And if this vicious cycle continues, this abnormal walking pattern further aggravates the symptoms. So immediately after the injury, it is advisable to use crutch for the ambulation. So there are various factors which needs to be kept in mind when you are preparing patient for ACL reconstruction. which are being psychological factors as well as patient's physical factors. So there should be psychological readiness from the patient to undergo the surgery, because if they are not ready, they are not going to follow the rehabilitation protocol. And there is a difference of readiness amongst adolescents as well as adults in terms of rehabilitation as well as further exercises. So which patients do need ACLR? So literature have shown that patients who have knee instability and they have activities of higher demands are usually a good candidates for the ACL reconstruction. Patients with lower moderate activity demands can be treated with the rehabilitation. And in case of the patients where there is a knee is a stable, there is no instability, they can be very well treated with conservative management. Ideal time for ACL reconstruction, so there is not much difference in various studies, early and delayed, but still when you are planning early ACL reconstruction, so usually it is because for the associated injuries like meniscus and cartilage. Active patients usually who are active and activities of high demand, they can be treated early. Usually better to operate on these patients minimum after 3 weeks, so that the chances of arthropfibrosis is less. Then other than all these swelling, edema, hypothermia and range of motion, everything is taken care of, then surgery should be advisable when patient's quadriceps function is almost 80% of that the non-involved side. So when you want to think about this, then you need to plan the patient's rehabilitation. So there are various goals which are involved in these, which being reduction of the swelling, retaining the range of motion, retaining of the muscle size and strength, normalize the gait pattern, and along with the same cardiovascular fitness in these patients. So for swelling control, we all very well know about the rest, ice pack application, compression and elevation. Use it, let the swelling settle. Once the swelling is less, then we can start working on patient's range of motion. So there are various exercises involved for this, being a stationary bike, hill slides, prone hangs and wall slides. So stationary bike is a very good exercise, so that can be started in the early period. So like if you are working, you think that patient's extension is less, keep the seat elevated. If you want to work on a flexion, keep the seat down, and 20 to 30 minutes per day exercises on a stationary bike can be advocated. Then another one is a hill slide, by keeping the patient either prone or sitting with the help of hamstring or the strap. With the with the help of the hamstring or any strap, you try and flex the knee, get maximum knee bending possible, so that helps in reduction of the stiffness. Then for the patients who have fixed flexion deformity or flexion contracture, you can start them with the prone hangs, where patient is on the edge of the bed, then edge of the bed, and then with the help of let gravity, let the knee become straight, and then further straightening can be achieved by pushing with the opposite or normal heel. Another one to get the range of motion is a wall slide. Patient being prone with the affected foot on the wall, and gradually patient tries and brings the foot down, flex as much as possible, and further flexion can be achieved by pushing with the normal heel. After range of motion, the next is to get the strength. So what are the things you need to look after for the strength? Being quadriceps sets, 4-way straight leg raises, heel raises, chair squats. So for the quadriceps strengthening, you for the quadriceps strengthening, patient should be pushing the knee on the couch, giving a maximum pressure while contracting the quads, and giving the dorsiflexion, maximum dorsiflexion of the ankle. So that gives static quadriceps strengthening. So this should be advised after the range of motion. Then another is a figure of four-way straight leg raises. So where I'm not going to go through the complete video. So here flexion hip is joint is flexed with the straight leg raises. Then patient is taken onto the one side. Then hip joint is abducted. So that gives abduction of the hip. Then in a prone position, patient is allowed to extend the hips, and then in the same position on the opposite side, the affected side being on the couch, you need to do the adduction. That's inside of the hip needs to be adducted. So these are the four-way straight leg raises which can be started like this. Then next one being the raising of the heel. So patients are advocated to walk, stand on tiptoe, do the tiptoe and stand on both the heels simultaneously. If it is bearable and they are able to do it easily, then can be asked to do one leg at a time. So regular repetitions. Then another being the half squats or chair squats, where if in the initial phase, patient may use a support and try and do half sit-ups. Once they are compliant and they are in control of this squatting, then they are advised to do further squats up to the level of chair and do the regular repetitions. Then another thing, along with this, once the strength has achieved, main thing is to do the normalized walking pattern of the patient, because this is very much important. If patients walk with a limp, then they still don't get their normal walking pattern. So they should be advocated to walk with the bent knee, keep the foot straight while in the swing phase, don't turn foot out or inside, don't lean on opposite side, and don't swing leg out to the side of the body. So normalized walking pattern is done. The next thing is working on the cardiovascular fitness. So things which are involved in this is exercise bike, use of elliptical trainer, and swimming. So the same thing, a stationary exercise bike, which we have already mentioned. So main tips are here, work only on motion rather than on the resistance. Use of the elliptical trainer, and when patients are using this elliptical trainer, they should be very comfortable and they should be walking without limp. You cannot advise them to do these exercises when there is a pain. And then another is being a flutter click swimming exercises, where it is just a fluttering, what shown in the below video. Patient should avoid doing any breaststrokes or whip kicks, so that can further cause more pain. So after that, the choices comes which graft to be used. So these are the various reasons which are mentioned. So I think Dr. Saxena will be talking on that. Then no perfect, there are different graphs. I think we'll come to know in the next lecture. So take home message is the road to the successful outcome of ACL starts the day patient sustains the knee injury. Psychological readiness of the patient has got good importance, and before you planning for plan to do any ACL reconstruction, the knee should be quiet. Otherwise, patient may land up in a further stiffness. Thank you very much. I have a few announcements to make. A sincere request to everyone to become a member of Indian Arthroscopy Society. It is our parent society, and I think we should all become member of this society. Another thing is we have Ias-One coming in this September. There are various opportunities for fellowships and awards, so everyone should become a member of, register for the Ias-One. And last one is next month end, we have scheduled Pune knee course. So please do register for PKC. We have got over 15 live surgeries and good power pack program. Thank you very much.
Thank you, Dr. Sandeep. Excellent few tips regarding how to prepare the patient before ACL. I invite Dr. Punendu Saxena sir for his talk on grafts in ACLR.
Thank you. We have got quite a few choices now for our ACL reconstruction. Bone patellar tendon bone graft, which is the oldest and the most well established, I would say, hamstring tendon grafts, and quadriceps tendon graft with or without one bone plug, peroneus longus graft, and allografts. Let us discuss the pros and cons of each one of them. This is patellar tendon graft. We all know it very well. We can have, we do have bone plug on either side. And the good thing about this is it is very good day. Day one is strength of this graft is excellent, superior to native ACL, obviously. And due to bone-to-bone healing in the tunnel, more rapid graft integration has been demonstrated. The most important and probably the best thing about this graft is the lowest re-rupture rates as compared to all other grafts shown by many authors. However, the biggest problem with this graft is anterior knee pain, which is seen in up to 42% cases. It doesn't affect, however, functional score and return to sports kind of scores. Another thing is the weakness of quadriceps mechanism. The peak torque for quadriceps becomes lower, even, especially when we compare it with the hamstring tendon grafts. Larger incision, especially in the front of the knee, is not sometimes cosmetically appealing, and there is theoretical risk, although not seen in reality, increased risk of infection. Fracture of patella is another problem that may occur. It may occur during surgery or maybe even after, even under physiological loading. But again, they are manageable and rare. We have got a fixed length of the graft, and in anatomical abnormalities like patella basa and alta, the length of graft may be challenging for the need. Increased incidence of radiological arthritic changes. Long-term studies have shown that the patients with patellar tendon graft, they have got more radiological changes of arthritis. However, clinical significance is not much. The next is our hamstring tendon grafts. We take two tendons and double them up. So we have got a quadruple graft available to us. It has got reasonable strength, again stronger than native ACL as well as PTB on day one. Because it's graft all the tendon, we can decide its diameter, so it fits well, and graft tunnel mismatch is less likely as compared to patellar tendon. There is minimal incidence of anterior knee pain. Donor side morbidity is low. However, cutaneous nerve involvement can cause problem, but modified incisions are described with less likelihood of cutaneous nerve injuries. Re-rupture rates. This is the problem with this. Re-rupture rates are higher than patellar tendon bone graft, and it has been shown in many clinical studies. A graft of less than 8 millimeter is more likely to fail. And how to predict it? I think the MRI can help, and even some studies have shown it correlated with the height of the person. But this is something we should keep in mind. Another problem is hamstring weakness. You take out hamstring tendon, and the person who is to play football will have problems. So peak isokinetic torque remains low even after 5 years, it has been shown. But then there are some other studies. This is a study by Mohammadi, which shows that there is no difference in flexion strength. However, again, the second study was only among footballers, that also about a small group. So most of the people consider that hamstring tendon grafts lead to hamstring weakness, and they consider it when they make decisions. Tendon bone integration obviously takes longer time, longer than bone to bone healing. So initial pull out strength is inferior to patellar tendon, but clinically there is not much of difference in 6 weeks time. Again, higher incidence of canal widening, which is, after a few years, if you would see that you can see a big wide canal in your x-rays. So this is a higher rate of radiological canal widening as compared to bone patellar tendon bone. And probably it is related to fixation technique, the suspension techniques. And it does lead to higher rates of laxity and positive Leachman tests in these patients, but no difference in patient reported outcomes and long-term joint degenerative changes. In fact, degenerative changes are more common in patellar tendon. This is the third choice. This is quadriceps tendon graft, which is becoming more and more popular lately. And as you can see, we can choose the 7 to 8 centimeter of this quadriceps tendon. We can choose the width according to need. We can take full thickness, but most of the time we take we leave the most posterior part of aponeurosis, which is made up of intermedius behind. And this is how we take this graft and use it. You can use it with a part of bone from the patella. So it has got adequate cross-sectional area and length. It has got possibility of using a bone plug on one side, making healing a better prospect of the healing. It is cosmetically acceptable, and there are less patellar complications with this. Anterior knee pain and kneeling discomfort is less. Outcome scores and laxity are comparable to bone patellar tendon bone construct, and probably a bit better than hamstring grafts. Strength and re-rupture rates are also comparable to bone patellar tendon bone grafts. However, weakening of quadriceps mechanism is still there, and that can be avoided by using partial thickness graft as shown by some of the authors. There could be scar related problem, but there are special instruments from Casros where you can take this graft out with a small incision. Still, it is new and long-term and multicentric studies are required. Now, perennial longus graft is again an option. Behind the medial lateral malleolus, you have got two tendons. The posterior one is perennial longus, and you can take graft from there. And again, the good thing about is adequate length, diameter, and strength, minimal donor site morbidity, no anterior knee pain, and it is valuable in multi-ligament injury scenario. I think Tapasvi and our Anshul has wrote a paper describing its use in posterolateral corner injuries, I think. So when we need many tendons, this is also there in our hand. It can be used in presence of grade 3 medial collateral ligament injuries where you would not like to take the hamstring tendons. And results are comparable comparable to hamstring tendons in terms of biomechanical testings and functional scores. Again, once you take it out, there is a possibility that the eversion torque at the level of ankle is reduced, and so it may limit performance in a sports person. However, in normal daily life, it doesn't affect much. Injury to peroneal nerve can happen, but again, if you keep the tendon strapper parallel and superficial to fibula and stop 5 centimeter below fibular head, the chances are almost nil. Need more long-term and multicentric studies. Allografts, we don't have much availability of allograft here, but they are available and would soon become available here as well, I would think. And you have got all the choices. In general, no donor site morbidity here. Surgical time is therefore less, and possibility of obtaining different lengths, diameters, and bone plugs exists. The possibility of disease transmission is there, so one should be careful about it. Another important thing is when we make these grafts, sterilize them, then either we use radiation or we may use chemical sterilization techniques. And both of these techniques are known to cause reduction in strength. And with chemical substances, inflammatory responses can be seen due to some chemical residue as well. So delayed incorporation is seen as compared to similar autograft. For example, bone patellar tendon bone autograft and allograft, the allograft will take much longer to incorporate. Similarly, the re-rupture rate is very high, up to 5 folds higher than autografts that has been shown. So availability and cost is also an issue. So as we all know, there is no final word on what graft to be used, but as per activity levels, if we consider 3 levels of activity, elite athletes should have bone patellar tendon graft. Quadriceps grafts are picking up. Hamstrings are used only for certain sports, not all of them. For moderate activity and young persons, hamstring tendons and peroneus longus are good. And very old or older, not so active patients, you can use even allograft if they are willing to accept the higher failure rates at the cost of not taking off a graft. And for sports like football, especially wingers, use bone patellar tendon bone graft. But for sports like basketball, we use hamstring graft to preserve quadriceps. And in kids, we prefer hamstrings because we don't want to um, do damage to the tibial tuberosity. Thank you.
Thank you, sir. May I now invite Dr. Suman Nag for video technique demonstration of hamstring graft harvest.
Respected chairperson, seniors and dear friends. So starting of any ligament reconstruction is a graft harvest. So today my presentation is on hamstring graft harvesting video technique. So before going to the video technique, we should know the anatomy first. This is the picture showing medial aspect of the knee, where all the 3 tendons, the sartorius, semity and gracilis is inserted. Sartorius here forms a sartorial fascia which covers both the tendon, gracilis in the proximal and semity in the distal part. Gracilis is a round tendon which can be palpated well with your finger, and semity is a flattened kind of tendon but much thicker than gracilis. So when you dissect, you can see the sartorial fascia covers both the tendon, superiorly the gracilis, and below the semity, and below it the medial collateral ligament is there. There is a nerve we encounter while taking the graft is saphenous, the infrapatellar branch of the saphenous nerve, which is usually injured, and the patient complains a paresthesia in the outer aspect of the leg. So nowadays people are shifting to oblique incision instead of vertical incision. So surgical tips: while taking graft, we keep the knee in figure of 4 position. A 3 centimeter oblique or vertical incision is given almost 3 finger or 5 to 6 centimeter below the medial joint line, and 2 finger medial to tibial tuberosity. The sartorial fascia is palpated and is exposed and splitted. The gracilis is situated superiorly, and the semity is inferiorly, should be identified and dissected. The right angle clamps are helpful to isolate these tendons. Ethibond loop is placed around the tendon once it is isolated. All the fibrous attachments must be freed, palpated along and around the tendons all up to the hiatus. Then the tendon stripper is used to harvest the graft. The sustained force is applied along the tendon without rotating the stripper. If the tendon stripper doesn't pass easily, stop, make sure you clear all the attachments before pushing it too hard, which may lead to premature amputation of the graft. So this is the incision, oblique incision we're giving. 3 fingers down or 5 centimeter below the medial joint line, medial to the tibial tuberosity. Achieve hemostasis. Dissect through the subcutaneous tissue and fat tissue up to the base. You may find a few veins here. It should be cauterized sequentially. At this stage, you can feel the tendons with your finger. Remove all the fat tissue with a gauge piece so that the anatomy will be clear here. Palpate the tendons with your index finger. The tendon slips below your finger is the gracilis because it's a roundish structure. Now lift the sartorial fascia just below the gracilis and split it. So now superiorly is your gracilis tendon and inferiorly semity. With the help of a right angle clamp, isolate the gracilis. Take it out to the wound. I use a blunt bone hook to give sustained traction while releasing all the attachments. The facial attachments should be released one by one till the hiatus. You should feel all around the tendon. Just below the gracilis, you can isolate the semity. Semity has got few more attachments or vinculi. The major one is attached to medial head of gastroc. It should be released. With a scissor and blunt digital dissection. Pull the tendon gradually and feel the facial attachments one by one. Cut it with scissors. Once you're sure all the attachments are clear till the hiatus, you can detach the tendon. Before doing it, you can pass a Ias-One loop. You can take extra length of periosteum with it to get little more length. Now the Ias-One number 5 loop is passed. The tendon is detached from its insertion site. Now you're ready to harvest the tendon with a tendon stripper. Put sustained traction with the help of this Ias-One loop and push your stripper in the axis of your tendon without rotating it. The semity graft harvested. Now the same process is repeated with gracilis. Loop of Ias-One to secure it. Detach the tendon from its insertion site. You can use a clamp for extra security. Now the tendon stripper is inserted. So the tendon stripper is pushed through and the graft is taken out. Thank you.
Thank you, Dr. Suman. Now I'll invite our host and organizing secretary, Dr. Anshu Shekhar, to present his video technique of bone patellar tendon bone graft harvest.
Okay, so we've seen the hamstring tendon graft harvest. Now we will see the other common tendon which is used for reconstruction of the anterior cruciate ligament. These are my conflicts of interest. BTB is my favorite graft. No soft tissue can ever match bone-to-bone healing. And our elders were always right in choosing BTB when they started doing ACLs ages back. So this is my technique of how I harvest a BTB. This is how I have learned from Tapasvi sir. So this is about a 6 centimeter incision which lies medial to the tendon. It is not a midline incision. This helps avoid scar right in the midline, which is probably better for kneeling pain. So an incision then created. So it starts right at the inferior pole of the patella, extends down till about the tibial tuberosity base. Full thickness fasciocutaneous flaps are raised on both sides. So the medial flap you see is slightly larger. That's because this same flap is then utilized for creation of the anteromedial and the accessoromedial portals. And similarly on the lateral side, the flap goes all the way till I see the lateral edge of the tendon. So a largish retractor goes on the lateral side, a small catspaw on the medial side. The paratenon is then incised carefully. This is an extremely important structure. The paratenon contains signaling cells and progenitor cells for tenocytes. Hence, it is very important that the paratenon is incised sharply and dissected in its entirety. So with a 50 number knife, we can go and release the paratenon to expose the tendon on the medial side along its entire length. And also this same step is repeated on the lateral side till we see the shiny tendon below. So that's extending right till where I would harvest the bone block. So that's the paratenon flap on the medial and the lateral side. The lateral side is then held out with a retractor. The tendon width is then measured. The central third is marked. So in this case, about 34 centimeters was 34 millimeters was the width. Central 10 millimeters is marked out. And then I use a 15 number knife freehand to incise the tendon parallelly with the intention of getting me a 10 millimeters width of the tendon. And there are special double knives available. It's not always necessary. And it is important that we completely cut the tendons from anterior to posterior. If there is no complete transection of the tendon A to P, then there might be some fibrillations, and that while transecting the bone, that will interfere with complete removal of the tendon. So then the retractors are pulled superiorly, and the length of the patella plug which needs to be harvested. So I prefer an 18 millimeters, just short of 20, because never faced issues with 20. This is an important instrument. A small micro saw is used, and this is used on the medial or lateral side first to cut two parallel strips of the patella. So we need to be very careful when this is being done. Using a drill bit and then a mallet with a osteotome is not a good idea. You must have a small saw if you want to do a BTB. There can be no two ways about it. So these are strictly speaking not parallel to each other. You see, I'm trying to converge the two, which I will show eventually as to how this is utilized for designing the plug which goes into the femur later. So they are not completely parallel, they converge slightly. And then the cut superiorly, sorry for that hand. So the depth of this cut is about 6 to 7 millimeters. So that blade of mine is 10 millimeters, that's 1 centimeter. Then I prefer to drill the patella plug in situ instead of removing it and doing it on table. That's a 1.8 millimeter drill bit. And then I mark my tibial sided bone plug. It starts from where the tibial tuberosity begins proximally and extends for 20 millimeters distally. So that's a 2 centimeter bone plug, which I prefer on the tibial side. Now, this cut again, they are parallel to each other, but going from A to P, from anterior to posterior, they are not parallel to each other. They would be directed at about 60 degrees so that we get a triangular cut, and we'll see how that is a useful tool. So the two parallel cuts are first made on the ventral surface of the bone, and then the inferior cut. So this is targeting a 2 centimeter long bone plug. So that is how I would make the distal cut. Now we should make sure we can go full thickness, because this blade, this small saw blade that I'm using is not too long to perforate the entire tibia. And once again, I use a 1.8 millimeter drill bit to drill 2 parallel drill holes. This is a better idea than doing it on the table, because then the tendon tends to slip out and can fall. Never had that complication, thankfully. So we need to mark that. And then we use a 10 millimeters osteotome. Try to push it into the cut bone ends and then hit it with the hand. No mallet. No mallet is ever used in the harvest of the BTB. That is why, thankfully, I've never had a patella fracture also. And then the part of the tendon which is attached to the superior end of the tibial tuberosity is carefully dissected out. The fat which is then stuck underneath is removed. We can use Metzenbaum scissors or a 15 number knife, whatever is suitable. So it is again important to resect this fat pad completely so that we can palpate the inferior end of the patella plug, and then eyeballing a width of about 5 millimeters, I use the same plug and drive in my saw blade for about 2 centimeters, 20 millimeters, and then wriggling it out. That's the BTB that I have got. So you see the patella bone, this is the triangular, this is what I was talking about. So if you angle the saw blade, you get a triangular plug like that. This bone is then removed. We need to make it trapezoidal. And then the patellar bone is also fashioned such as to remove any extra bone. This bone is then used to of the paratenon, for which I use a 2-0 vicryl on a reverse cutting needle. So that you see is the complete closure of the tendon. The defect site in the bone, in the tendon, is not visible at all. And the drill holes are then used to pass sutures. I use number 5 ethibond or number 5 high strength sutures. So one hole in the patella, the other suture passes through the bone patella junction. Because drilling 2 holes in the patella, I had issues in the past, so stopped doing that. One hole suffices most of the times. And then of course, lower down 2 holes have worked. So I prefer 2 holes still. Once again, number 5 ethibond passed across and then measured equally and then cut. So once this is done, so that is our completely harvested BTB plug. We measure it. This is about 80. I use a technique of drilling through and through, then measure it. This is 9 millimeters. Now, unlike the hamstrings, which should pass tight through your sizer, the BTB should be slightly looser. And then we see that is the patella bone plug, which is shaped like a bullet, the sutured tendon, and then the patella, the tibial plug, which will go into the tibia. So that is the entire graft now ready. I always use vancomycin wrap, 50 mg of vancomycin in 50 ml saline to give me 100 mg per ml dilution, which has kept ACL graft infection rates to 0. And that's it. That is, in my opinion, the gold standard graft for ACL reconstruction. Thank you.
Thank you, Dr. Anshu. Nice demonstration. All the steps were demonstrated very well. Now I'll again invite Dr. Mukesh Mehta for his talk on anatomical ACL reconstruction principles.
Good afternoon, everyone. So this is most common surgery done by all arthroscopic surgeon, anatomical single bundle ACL reconstruction. Some of the slides will be repeated as harvest shown by Suman and Anshu. So always do surface markings as a principle so that you are not wrong. To start with, always evaluation and anesthesia should be the first thing. You should see the pivot grading, because if it's grade 3 pivot, you should look for root tears and ramp lesions or some anterolateral instability to deal with. In harvesting, a few points Suman has very well mentioned about it. Only few points. Always try to take about a centimeter of the periosteum. That increases the length of your graft, and also periosteum have a good healing potential. These vanculas need to be very well cut out, and the important point that your curved scissor tip should be away and not towards the tendon. Otherwise, by iatrogenic, you may cut the tendon as well. And usually see for two vanculas, because usually there are two vanculas, and if there are no vanculas seen at all, see that it's a gracialis and it may not be a Semitic graft. And once you finish harvesting, you start preparing the usual way, what Suman has shown. See that the diameter of the graft should not be less than 8 millimeters, because the failure rate below 8 millimeters of hamstring graft is really high. So you prepare with either on graft board or on tensioner, and then measure it and see that it's 8. If semi-T quadruple is not giving, harvest the gracialis and make it 8. Tension it on the graft master board and cover it with the vancomycin soaked gauze. Next is usually you need to make two portals, high anterolateral and anteromedial. But if you want to visualize the footprint in total, you can also make an accessory anteromedial portal. Initially, it's a good thing to do accessory anteromedial portal if you are doing a horizontal technique or a portal technique to do femoral tunnel. So you see the femoral footprint is oval in shape. So that's the top, and that's the residence ridge, and behind that is the bifurcate ridge. So that is what your, in the upper part is your AM bundle, in the lower part is your PL bundle. That's the anterior posterior, and that's the superior inferior, the whole dimension of femoral footprint. So always go and identify the footprint well, and then you start preparing your tunnel. I usually use a offset guide, 6 mm femoral offset guide I always use. It gives me a good sense of feeling that I will not fracture the posterior cortex. So knee should be flexed around 110 degrees if you're using a transportal technique. Pass your guide wire, see that you should not scuff the cartilage on the medial femoral condyle. So while doing it, always have a look. So when ask your assistant to push the drill with hand, do not use drill directly till it reaches the condyle. And then you do full up to lateral cortex cortical break with 4.5 mm, and then with your respective graft diameter drill up to 15 or 20 millimeters, whatever your graft length is. So minimum I prefer to keep 15 millimeter in the femur, or up to 20 also you can keep, and then again go into the anteromedial aspect and see that you have not done any damage to the posterior condyle, or your graft position is quite well in the desired, so that you may not do the same mistake in the next case if it's not in proper position. So as I told you, again go and see, and that's what the original footprint is. And we as a single bundle, as even mentioned by Dr. Anand sir, okay, here is the most fibers. So we as a single bundle, mostly we try to recreate anteromedial bundle, and the posterolateral aspect of the bundle is usually not reconstructed with our anatomical single bundle ACL reconstruction. So that's what your ideal single tunnel should look like. For tibia, the footprint of the tibia is not circular, it is C-shape or what, but most of the times when you see the tibial footprint is somewhat rectangular and is very big, as mentioned by Dr. Anand sir. It's quite big. That's the anterior aspect, that's the lateral aspect, which is very well flushed with the anterior horn of lateral meniscus. That's the posterior aspect, and that's the medial, which is flushed with the medial tibial spine. So it's somewhat a kind of rectangular, or which is more anteromedially, more anteroposteriorly and less mediolaterally. The tibial footprint is quite big. So I always prefer to use a tip aimer ACL jig because I want my guide wire to come exactly wherever I'm putting my tip, unlike the elbow aimer where you have to rely on the distance key, you have to be 1 millimeter to 5 millimeter anterior. So see that you preserve the footprint and keep your tip exactly in the center of the footprint, and your guide wire exactly comes in the center. Sometimes you may have the guide wire which is not in the center. At that time, you can do some eccentric rimming with 4.5 mm rim and then shift it in the center of the footprint, and then try to preserve the stump, if you, and then, or else in this case I've removed it just to show that you are in the center. So that's the tibial footprint after you prepare. It's well, you don't damage the anterior horn of lateral meniscus, you are well flushed with the medial tibial spine, and you are well flushed posterior, but still anteriorly some part of the fibers are not covered with single tunnel. And then you do the graft measurement, and whatever implants you are using, adjustable loop or fixed loop. If you are using adjustable loop, you need to do marking of the whole length of the tunnel. If you are doing fixed loop technique, see that you over drill the tunnel by 8 to 10 millimeters for the turning radius of the implant, and then mark the desired length of the graft which you want to pull in. So in case you are using the adjustable loop, you can clearly see the flipping of the button under vision. Ask your assistant to gently pull the button in the tunnel, and your scope in the anteromedial portal, you can see how beautifully the button gets flipped on the lateral cortex, and then try to pull it, and then pull the graft inside to the desired direction. See that there should be no graft tunnel mismatch, because that will lead to early graft failure because of synovial fluid going between the graft and the tunnel. And for tibial fixation, if you're using a soft screws, see that it's one size above, pull the ethibond tightly and give a posterior drawer before, and then you put your screw so that you have a very stable fixation. And see that the knee is in 20 to 30 degree of flexion, except in morning's case where patient, it was a hyperextension knee. See that you fix the tibial side in neutral extension, otherwise patient won't get the desired hyperextension which she has already have. And that's what the final reconstructed ACL you guys look. A nice article given in JBJS, please go through it. They have given a checklist of how to do a proper ACL reconstruction, and see all these parameters what I have shown. They have given some, I am using, some I am not using it, but you can go through it and you can use this checklist. Keep this checklist whenever you do ACL reconstruction. So is there something which we can modify now to have more ACL graft in the single tunnel? Because we know after the double bundle by late Dr. Freddy Fu, which has given a new insight that we are not covering the footprint to the desired aspect what the original ACL has. So as I told you, the ACL footprint on the tibia is not circular, it's somewhat rectangular in shape. That is very well mentioned in literature, that it's a rectangular. And when we do TKR, we also see that the footprint is not circular, it's more anterior-posterior and less mediolaterally. So can we do something to get that original footprint? Even on the femoral side, as I showed you, it's an oval shape ACL. It's an oval shape, it's not circular. still we are reconstructing circular tunnels because we know the fate of double bundle. It's double bundle, double trouble. So everyone have now stopped using, at least in our country, no one does double bundle ACL reconstruction. So I have developed a technique where we have designed the special rectangular tunnels to convert the circular femoral tunnel into a rectangular femoral tunnel to enhance the footprint of our original ACL. This technique has been accepted in arthroscopy recently in March 2022. So I'll show you what modification I have done in that. So these are the special tunnels dilators which we have prepared. So it comes in the size of 8 by 8.5, 8 by 9, 8 by 9.5, and 8 by 10. So 8 remains the anterior-posterior if you're on the femur, or if you're on the tibia, the mediolateral remains 8 mm. And gradually you convert that 8 into 8 by 10. As you see, I am dilating the circular femoral tunnel with the help of my punch through the same anteromedial portal with the knee in the same 110 degree of flexion. What happens with this? This is what your original ACL footprint on the femoral side is. This is what we recreate with our single circular tunnels. This is what is recreated with the rectangular punch. It's a simple tunnel dilator. So the concept here is to convert a circular tunnel into somewhat a rectangular or oval tunnel to increase the footprint coverage as to what the original footprint is. Same as you see on cadaver, this is what you recreate with the anatomical single bundle. And when you use the same tunnel, you can see the change in the dimensions of the tunnel from circular to somewhat rectangular and covering more amount of footprint on the femoral side. Similarly, on the tibia, if you see the single, you may agree that this is the proper single tunnel in the tibial footprint exactly in the center, but still we are not able to cover the posterior part of the footprint. So this is the same tunnel dilator coming from the outside tibia to the inside the tibia, and it converts the circular into a rectangular tunnel. So this is what is the original footprint. This is what you recreate, and this is what the new technique recreates. So now how to put a graft in this rectangular tunnel? Even on cadaver, if you see the tunnel dilator giving you a shape of the original tibial footprint. So here the same hamstring graft is used, and it's a graft squeezing technique. In the sense, if you have a 9 mm diameter graft, you usually drill with 9 mm diameter and you pass your graft and you fix it. So here you have to drill with 8 millimeter to form a circular tunnel, and then gradually the mediolateral will remain the 8, but anterior-posterior will become 10 because the dilators are of that size, 8 by 8.5, 8 by 9, and sequentially. So you keep mediolateral same, but you increase anterior-posterior. And when you pass the graft, it squeezes from one side and it will expand on other side because it's a soft tissue graft and it will take the shape of the hard bone. And once you see that same thing from the posterior medial portal, you see that during flexion extension, you are having a sort of double bundle like effect. When you extend the knee, the posterolateral bundle is getting taut and the anteromedial is getting little lax. And when you flex, vice versa occurs. So you can fill the graft with the same tendon, but with a rectangular tunnel, having more collagen and giving a sort of double bundle like effect. This, as I showed on the cadaver also, this anterior aspect of the graft will go medially and the posterior aspect will go laterally. So you will create a sort of, I may not say exact double bundle, but a sort of. And does it gives a good graft healing? Yes, this is one of my patients, 7 months post-op MRI. You can see how robust the graft has healed up very well, which Anand sir also told it takes 1 year, but you see here in 7 months, the graft has been healed very well. Even on the, here you see the reflective feature of the tunnel with the graft in. So this is a new technique which has been developed by us in Nagpur. We have recently done about 8 to 10 cases so far. So long-term results are yet to be there. So graft diameter should not be less than 8 mm principally wise. Visualize and identify the femoral and tibial footprint. Be in the center of the footprint. Anteromedial or accessory anteromedial portal, whatever you prefer. No graft tunnel mismatch should be there. And you need a very stable fixation to help ligamentization. Thank you.
Excuse me. Before we push on to the question answer session, we'll have the felicitation of the dignitaries, because after that, after felicitation, Dr. Anshu and Dr. Sachin sir will push off for live demonstration. So may I request the chairpersons to kindly honor Dr. Anand Joshi. Dr. Anand Joshi. Dr. Purnendu Saxena.
Hello, everyone. Greeting from United Kingdom. I'm going to talk on the setup of shoulder arthroscopy, hoping to give you some tips and tricks. I would like to thank the Association.
And after Purnendu, I would request the chairperson to please honor the person sitting just beside me, Dr. Suman Nath. और उसके बाद अंशु. And finally, I'll request the chairpersons to please honor the organizing secretary as a speaker, Dr. Anshu Shekhar. Dr. Anshu. I now request Dr. Neelam Kothari, sir, to please honor our chairpersons and by a floral welcome. I now request the chairpersons to take over the seats again and conduct the question answer session. And Dr. Anshu Shekhar and Dr. Sachin Tapasvi will now leave to prepare for the operative session.
I request the delegates for any questions to our faculty.
I congratulate Dr. Ladda for such an innovative technique. How you decide that that 9mm graft will put on that square or rectangle shaped? What will be the?
Sir, as I told you, if you have a 9mm graft, you have to drill first with 8mm tunnel, circular 8mm tunnel, and then the punches are designed 8 by 8, 9.8 by 8.5. 8 mediolateral will remain the same, but it will convert to 8.5. Then 8 by 9, 8 by 9.5, and 8 by 10. You can only do 8 by 10. You can't go 8 by 11 because it's a 9mm graft. So we have 8 mediolaterally and 10 anterior-posteriorly. So it will squeeze from one side because it's 9 and we have 8 and it's 10. So
Sometimes it may be quite tight, or sometimes it may be quite jammed, or sometimes it may be loose because
I am saying it's like a soft tissue going into a heart, so it will take the shape of the hard bone. So it's only up to 2mm, like 8 by 10 and 9mm graft. It squeeze easily and goes up.
Then where you put your screw, interference screw in the tibial side?
Tibia, it goes. You have to put 8
anterior or
mm,
posterior?
you have to put 10 mm. And it all depends कि आपका डालने के बाद अगर आपको लग रहा है कि थोड़ा सा mismatch mediolaterally है या anterior posteriorly है, that way you put your screw. But mostly I put it in the posterior aspect.
Is there any chance of cortex blowout in the posterior part? Making this?
I don't think so, because I am using in my 10 cases, I have not blown out anything because I am using offset guide. So I am very sure that I keep 2mm bone there. And as it's a sequential dilatation, so if you feel with only 0.5mm, you are going much behind. So in next, you can just change the angle a bit and you can prevent that damage.
Thank you.
Right. Thank you. Nice. Huh. 22, ma'am. Yeah.
Mismatch between the size of the hamstrings and the rectangular shape.
That's what it's
And
not
is it going to create problems in the future with the windshield wiper effect?
It's not, because as I told you, the diameter is 9. and
Yes.
it's 8 by 10. So being soft tissue, it squeezes well. So in 10 cases, I've done MRI so far in 3 only, because they have not crossed
So
6
do
months.
you use a cortical endo
Same.
button?
Yeah, same.
Or do you use an interference screw at the
No,
femoral
on
tunnel?
femoral side, same adjustable
principle.
loop or fixed loop. On tibial side, same interference.
Good. And did you get the ethical clearance for this and from where?
No, I have not done a prospective study so far. It's only the technique which has been accepted.
And
So
how do you tell
ethical-
your patients that you're going to do a new thing?
अभी तक नहीं बोला सर.
अभी बोला नहीं ना, बस वैसे रहने दो.
यहाँ तो अभी
चलो.
आपको to be very frank,
खाना खाते हैं.
ethical committee का अभी approval के लिए भेज रहा हूँ.
भेज दे.
Now I am doing a
Because
prospective
your
study.
paper has been accepted for publication, that is the first thing they will ask you. Where is your ethical committee?
So I have
Because it's
now
a new
started
technique.
study. So the paper is with ethical committee to give approval. Right.
Well done.
Your femoral side, I'm convinced with, but on the tibial side, when we are already squeezing the graft with a screw, so what that rectangular space, when the screw has already gone, your graft is totally bang on the wall.
Very good question, sir. But I always keep my screw 5 millimeter below the tunnel. I don't want the screw in the aperture, because the healing is at the aperture. So at the aperture, it's still rectangular. The screw is 5 millimeter at the subchondral bone, not in the tunnel. It's still controversy. So it's basically because we know with single bundle, we are recreating the footprint by 50 to 60% of the original. With this, the footprint enhancement is by 25% more. So you will have more collagen, you will have more bundle with same single tunnel. Thank you, sir.
Any more questions? So we'll move to the lunch and then we'll meet. after
Yeah,
half an hour.
this brings to the end of this session and the forenoon session as well. And I don't know if you are all are realizing it. There is a tempting smell and odor coming from this side. So we are all, invited for a lunch. We will take lunch, and in the meantime, if the operative session starts, we'll come and sit here with our lunch so that we can see the operation steps going on there. So happy lunchtime.
Hello, I'm very excited to come to Pune here in the end of July. I will be doing meniscus transplantation and also some complex knee surgery. So please join us in June, and I'm excited to see you all there.
Hey. Hal. 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 Hey. Hal. हेलो चेक चेक हेलो आ रहा है क्या हेलो चेक 1 2 3 हेलो चेक 1 2 3 क्लियर है क्लियर है हाँ सर
हाँ गुरुजी क्लियर है हेलो क्लियर है
हेलो चेक एक मिनट में ओटी में जा रहा हूँ ओटी में
मेरा आवाज क्लियर है क्या वहाँ पे
हेलो चेक चेक
मेरा आवाज हाँ आपका क्लियर है मेरा आवाज क्लियर है हेलो 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 हे चेक 1 2 3 हे चेक
हाँ
ओके
ठीक है सचिन आएगा तो बढ़ाएगा
ठीक है ओके
ओके बाय
बाय
Good afternoon. I'm sure we have had enough to eat. Ladies and gentlemen, can we move to the seats? Because the surgeons are getting ready. And it will be useful if we start on time. You're permitted to bring your plates to the table. Everyone, please come this way.
Hello, I'm very excited to come to Pune here in the end of July. I will be doing transplantation, demonstration, and also some surgery. So please join us in Pune. I'm very excited to see you all. Hello, I'm very excited to come to Pune here in the end of July. I will be doing meniscal transplantation, demonstration, and also some complex knee surgery. So please join us in June. I'm very excited to see you all there.
अंशु already? अच्छा तो फिर उनको बोलो टेलीकास्ट चालू कर देंगे तो पेन टेप तो हो गया.
Can I please request everyone, especially in that corner, Harikesh, bring your plates over here. तो संजय विजय को फोन करूंगा, उसको जूम कॉल पे लूंगा.
Hello. Yeah, I think we all had a sumptuous lunch, and now it's the time to get back to our seats to enjoy the live surgical session. Very soon, it will be telecasted here, and we'll see from the scratch the painting, the draping, the position, everything, and the surgical steps by none other than the master, Dr. Tapasvi sir. So I request all of you to please be seated here. So the moderator for this session will be Dr. Anand Joshi and Dr. Tantuve Sahab. I request Dr. Joshi and Dr. Tantuve to please take their seat.
Abhishek, पुढे येऊन बस, सगळ्यांना बोलो.
I request Dr. Tantuve to please take the seat of the chair.
I treat you what we do of your. If we want.
Hello, check, check. Hello, check.
Hello. कि जो नेक्स्ट
Hello. Hello.
आवाज ठीक है? क्लियर?
या हेलो.
आवाज ठीक आ रहा है?
हाँ, यहाँ पर आवाज ठीक आ रहा है. आप ओटी से बोल रहे हैं?
हाँ जी, ओटी के अंदर मैं कैमरामैन हूँ. एक मिनट सर आ रहे हैं वॉश करके, तो सर को माइक देता हूँ.
So, meanwhile, can we see the MRI film or the clinical history of the patient?
1 second.
So, what position they are using? What are the key points? Okay, okay.
ऊपर चलो स्पॉट कर सर would it be down the sir
Yeah.
Yeah, okay.
When are they sign in the auditorium?
तुम्हारे पास
Anshu, are you there?
Yes, I'm here.
Down करो down.
Anshu, if video signals are, if they are coming here, so can you show us the MRI picture and can we have a little brief of the patient history?
So this is Sachin speaking. I would like you to play the presentation which is loaded on the main console in the hall that contains the patient profile. Can you please start that?
Presentation number 14.
It is number 14, 14.
14 presentation chala.
14.
14 वाला presentation है? Yes.
Yes. Okay, do you have it?
No, still, yeah. So,
Yes, there you go. Yeah. So, yeah. Next slide.
Next slide.
So we saw her this morning in the clinical session. Next slide.
Yeah.
Next slide, please. And this is your MR scan. So from your left to your right, you have three pictures. You are looking at the one on your extreme left is the sagittal image, which is showing a completely torn ACL. And these are the P1 and the P2 local images. The one on your extreme right is a representative coronal image. You see in that particular image that the lateral meniscus is showing a horizontal cleavage turn.
Dr. Tapasri, can I interrupt a minute?
Yes. That's the torn ACL, correct? Yeah.
The audio is not clear from.
Okay, we'll work on that in a moment. Audio clear here. All right, and in the extreme left corner, sorry, to the extreme right, which is the section, which is showing horizontal cleavage tear of the lateral meniscus. Next slide, please. Next slide, please.
Next.
Yeah.
ACL is torn.
Yes. Now, is next. Meniscus is normal. Next, the lateral meniscus shows a horizontal cleavage tore, and there seems to be an injury to the anterolateral capsule of the knee on the axial image. Next, please. The P1 images which show an intact MCL, an intact papillus, and an intact lateral collateral along with the papillotophyllid ligament. Next. Okay, so what we have is an adolescent. Next, she's a female elite athlete with an unstable knee with a high grade anterolateral or a high grade pivot shift. Next. This is the plan for her. Next. Thank you. And now you can go live. And then camera 1, outside picture, zoom. Out. So what we have here now is what you're seeing is what we have the knee and prep. Two ways we can do this type of surgical procedure. We can either use knee support and leave the leg hanging loose, or secondly, you can use a standard PKR position, which is what I am preferring to use as of now. So setup can vary from person to person. My preference is to use a standard PKR position. Sterile? Okay. I can go off to that side. Is the image and is the audio signal okay, or do you want any change now?
There is a brightness. Now it is controlled. Brightness is controlled.
Yes.
Audio still not good.
Okay, I will get.
We are able to see that you have taken the patient in PKR position, and the plan is arthroscopic ACL reconstruction with lateral extra-articular tenodesis.
Let's bring the quick demonstration of the camera और patient के बीच में आपको नहीं होना है. Side में रहो. देखो सुन. वहाँ पर कैमरा, यहाँ पर एक कैमरा. हाँ, अपना मुंडी बीच में नहीं होना चाहिए. हाँ. So again, this is a grade 2 pivot shift.
Yeah. We can see the pivot shift. Dr. Tapaswi, will your mic keeping little away from the mouth will... Can we...
Audio check, 1, 2, 3 check. Okay.
Yeah, it's better. Yeah, please continue.
So, so what do I want to do for her? Definitely an ACL reconstruction. Okay, she's a taekwondo player. When you do taekwondo, and pivot on that leg. So what does that mean? If you want to stand and pivot on the leg, you need good rotatory stability. And she's a female, and she has got hyperextension, and she's into contact sports. So all the red flags are ticked here for performing an extra-articular tenodesis. Pick it up, somebody. The choice that comes next. Please.
Anything you are planning for the meniscus?
So
Horizontal.
we'll probe the meniscus and then decide. PAT on, please. Yeah. And then we will decide as to what needs to be done for the meniscus. You know?
Okay.
Yeah. Is the audio okay? Hello, check.
Audio is okay type.
Okay type. Better than before, more better than before. One, two, three, check. बेटा मुंडी आ रहा है तेरे बीच में. मैंने क्या बोला? मुंडी नहीं आना चाहिए. कुछ भी नहीं. पीछे से कि अगर वीडियो आया तो आगे बढ़े पीछे से हम आपको either of these options, either you could take a Killing graph and do a hamstring, or you could do a BTB graph. A hamstring graph today, important, knock out the joint, mark out the patellar tendon so that you know where portals are. The important thing to understand, no, I don't want to light, I want camera. The camera thing. The important thing to understand is that you have your side, which is in the form of a triangle with its apex on the patella, which is now both on the middle, so that you can avoid this particular fat pad from getting attached. What am I going to do about the extra-articular notices? I'll enable camera 1. For the extra-articular notices, I have an option doing two procedures, so 3 procedures. This is my Brodie's tubercle. This is the fibula with the, what we have is the lateral epicondyle of to आवाज बंद कर अभी हाँ. And basically to create an extra-articular tenodesis, one can either use an ALL or an anterolateral ligament reconstruction, which is a free soft tissue graft, apex and posterior to the lateral epicondyle or to the fibular collateral ligament insertion, and then you need to make 2 tunnels at same. The other option is to use the iliotibial band, and for the iliotibial band, you can either harvest a strip of the iliotibial band, detach proximally, root it underneath the FCL and do a tenodesis there. Or what we will do is modify Ellison's procedure, detach the strip from the Brodie's tubercle, reflect it proximally, root it underneath the FCL and do a tenodesis there. So if you have low grade rotatory instability, then a modified Ellison's is good enough. If you have a grade 3 explosive rotatory instability, then a modified Lemaire, or in the case of a revision ACL, a modified Lemaire becomes the procedure of choice. Camera 2. So now we're going to be marking out the test tendons. We had an excellent video demonstration as to how should we harvest all the hamstrings graft, and I basically try and go through this procedure. We'll basically go through this number 15. We'll go through this procedure in a bit of detail as well. So I'm going to take a vertical incision. As you're aware, you can take a horizontal incision or you can take an oblique incision, and that helps sort out, most of your problems. Anything specific with respect to incision? Well, apparently the incidence of infrapatellar of saphenous nerve is lesser if you take an horizontal or an oblique incision, but the main issue why you get this type of neuropraxia is when you harvest the graft rather than when you are actually making the skin incision. So the nerve may get compromised when you are harvesting the graft and using a fair amount of blunt dissection either with your finger or with the with your with a wet gauze piece like a peanut is absolutely adequate. So we go in, we will now expose the Alida zoom in camera 2 to show them the fascia or the souterine fascia. The souterine fascia is exposed. I will take any blunt sort of type of device like a mop or a gauze piece, and then we will start feeling the tendons of the pes, which I can feel right here. Again, what type of tendon stripper should you use? One could use either open, closed. I like to use essentially is an open type of tendon stripper. Just leave the tendon attached to the pes and then detach it from the same. Difference between using either of them, again, it is a matter of convenience, what you prefer. Open the sartorial fascia. We've created a flap of the sartorial fascia. Now, this flap is what using at the end of the procedure. Somebody's hand is in the way. Is this me? Okay, yeah, I'll see it the other way around. Yeah. This is the flap that we will be closing at the end of the procedure. Okay, we always like to close the fascia. Close this flap because closure of this flap allows us to try and bring back some strength on the sartorial fascial side. Helps prevent some weakness and some pain over the same. Now, make sure that both your tendons are exposed. You can see both the cemetery as well as the gracilis. I like to harvest both of these because we will be making at least a 5-strand graft, and that is essential because you want to recreate the geometry for the same. Again, taking care to expose and find out the two components of cemetery is the one which has the various vinculae and the attachments to the middle head of the gastrocnemius. You want to look at all of these. Usually there are about 3. You can easily release 2 of them, which we are releasing right now. Of this graft and quite uncomplicated, which will then result in a good harvest without getting an amputation of the graft. For harvesting the cemetery, you want to direct your tendon stripper towards, and for harvest, your to direct it to towards the. I'm going to go and look at harvesting the gracilis. The gracilis will have attachments or vinculae to the tendinosis. Again, taking care to expose and to release them. Ashu Caesar is hati pe khali hai. Yeah, and to release them. Yeah, and once that has been done, the next harvest can be done very easily. So again, using an open type of a tendon stripper, and then going ahead, harvesting towards the adductor tubercle, and then we have got harvested both the cemetery and the gracilis. At this stage, I will go ahead and release both of these 15 blade. Go ahead and release both of these. Back table for getting fed. Okay. here is 100 mils of normal saline. Mils of normal saline, we have 500 milligrams of vancomycin. And when you have 500 milligrams of vancomycin, it forms a weak solution. Take one piece, it will approximately.
Video is on. Yeah. It's okay. Yeah, it's okay.
Once you soak your gauze piece in the same, then you will get a solution which is equivalent to 1100 grade, which is equivalent to a 0.16% of. I'm going to start off now by making light source on the. So my first portal is going to be very high. Light source on karna is going to be very high, just near the patella. To go very high when you come in, and now we start with our arthroscopy. I put in my arthroscope, feel the intercondylar notch, bring the knee to extension, and then introduce it inside the joint in this particular fashion. It should be freely and easily movable on both sides, which allows me to understand that I'm within the joint. Then we'll connect our irrigation inflow. We are using normal saline there, and then we start to proceed, and then go ahead and attach all our various components. So, airway takla ka Shwela? Okay, so we've started inflating the joint in this particular fashion, and we'll just go ahead and connect the light cable, and we'll connect camera for the same. Good. So now we want inside view large, outside view PIP, camera 2 of the outside view. So we start by doing a diagnostic round.
We are not able to see inside picture.
Are bhai sahab, Ali bhai?
Yeah.
Good. Okay. So now looking at the same, we will do a diagnostic round. I'm going in. There's a flap, the medial meniscus, the superior flap tear, as you can observe. Again, I'm going in the lateral recess. As I come down the lateral recess, I look at the lateral meniscus. This is the popliteus tendon, which we can see, and I will follow the popliteus tendon down and down and down and down till I reach almost the musculotendinous junction there. The horizontal band that you see going across the popliteus, which is right in front of you, is called as the menisco-popliteal fascicle. This is the anterior-inferior popliteomeniscus fascicle, and this on top is the posterior-superior.
So can we have a picture-in-picture outside and inside both pictures simultaneously? PIP, if possible.
Ali bhai, please do the needful.
Small outside picture and large inside picture. Yeah, it's
Camera outside view. So now this band that you see going across the popliteus is the area of the popliteofibular ligament, and when I rotate the knee, you can see that the popliteofibular ligament is becoming taut and is becoming loose. You can see it becoming taut and loose. So that is the popliteofibular ligament, which is what you can recognize arthroscopically. Right. So then we come back again to the suprapatellar pouch. We look at the trochlea. The trochlea looks fine. We look at the undersurface of the patella. That looks fine. We then move on to the central compartment of the knee. I will now flex 20 degrees of knee flexion. I will keep my leg positioned in the same way, and then we'll take a needle. And with the help of a needle, we will make a portal for the anteromedial portal. So about 70 degrees of knee flexion. When I make my portal, my needle should be touching the roof of the intercondylar notch. If it is not touching the roof of the intercondylar notch, it means I'm still low and I need to change the position of my elbow. So now I'm happy because the needle is at, and if I'm there, I would be able to avoid the fact down pole of the patella. So taking again an incision, type of incision, and then we take a straight clip or a straight hemostat, put it in there. And then we open it so that we don't make soft tissue that is entrapped in the cell. Foot pedal, shiver foot pedal, raise. अरे बोला ये शायद तुझे पर कुठे गेलो अरे कॉफी नको दुसरे कुठे गेली रेस अरे बेटा चल ठीक है शाहीन करते जाता So now the shift goes in, and with the shift going up. Are suction on? Are connect and suction on? हो गया क्या on? नाही झाला. Remove this. Pressure वाढवा. नाही यार नाही होते दुसरं ते शेवटी मला हे पिढन कर आहे का अरे नाही यार हा दुसरं आन्सर शेवटी okay now this which is coming and this visualize what you want to do so I'm going to remove some fat part. I like to do it now is to put my scope to the anterolateral portal and then I shift my scope to the anteromedial portal and do the same procedure one more time. Okay. Yeah. Once for the fat pad that you remove in the front, makes passage of instruments really simple. Otherwise, if you struggle with the instrument passage, it then just cuts a very sorry site and then you start. So just cleaning up the fat pad. A bit of the fat pad because fat pad so what we have now is that we can now see this thing going all the way to the back. Yes, it does look more rectangular, and this is her empty notch on the femur. You can't see anything there. The thing I will do is to put my scope in or the postmiddle compartment, and I will, if there is a ramp lesion, okay. So if I observe, because she has got hyperlaxity, I'm able to put it quite easily into the posterior compartment, and I will the degrees of knee flexion. After I will, it's a very unstable knee. The moment I try and bring the knee up, it wants to subluxate and rotate. So now we are going to demonstrate how to do pike resting to open medial compartment. Outside view large, inside view small, outside view focus where my finger is. Camera 2. Ali bhai, camera 2 focus. कुठे गेला अली? ओ अली, अरे बाहर मत जाइए ना अली साहब, रुके ना अंदर. हाँ, मुझे आउटसाइड व्यू बड़ा करके चाहिए कैमरा को और इनसाइड व्यू छोटा चाहिए. उंगली की इधर आपको
He's showing the pike resting of the MCL to open the middle side of the joint.
Yeah, so I'm doing pike resting of the MCL at just below the joint line on the tibial side, and I can feel repetition as I'm performing the pike rest. And you can observe in front of your eyes that the middle side is now opened up. Outside view small, inside view large. Outside view, inside view large. Then we will bring in and come in with my hook probe, and we will start palpating the medial meniscus. So the medial meniscus here is showing the presence of a horizontal flap tear, which is right here, and there is another flap which is exactly there, duckbill straight. So we're going to be taking a straight punching type of device, correct? And then I want to just trim off or remove the innermost part of the middle meniscus. So we just trim off zone 1. That because I want to check that if I trim off the leading fibers of zone 1, is there a concealed horizontal cleavage tear which is underneath the same? So I don't want to miss cleavage tear, that which may be there, electron develop, and then she will start getting symptoms on the medial side. So again, going ahead, medial meniscus and balancing it. Thank you. And now we will go ahead, look at the same, and the whole meniscus looks normal when we stabilize and we probe it. I'm now going to move to the lateral compartment. Bring the leg up, and I'm going to take it in a simple figure of 4 position and let the leg hang loose. Probe, please. Looking at the lateral compartment now, you want to probe very carefully the root of the lateral meniscus. The root of the lateral meniscus is intact. You can see the insertion of the root of the lateral meniscus. And there is another flap tear which is sitting right here. This seems to be a bit of a complex tear, which we will first start off by all meniscus excision 1 and then moving what the tear pattern is like. So just look exciting zone 3, I beg your pardon, not zone 1, but zone 3, which is the innermost part of the lateral meniscus. The cartilage, as you have observed, is completely normal. So we go ahead, we trim off zone 3 of the lateral. We'll get in a chondrotome or a shaver inside, and we'll just perform a limited balancing of the same using a shaver. Oops. Now hook probing, and we're going to feel the lateral meniscus. So bringing in a hook probe now, probing, This is the popliteal hiatus that you see. This is the anterior-inferior meniscus popliteal fascicle. And on top of what you see there, which is running meniscus fascicle. The meniscus is now stable. There is no need to put any sutures in the meniscus. And now we can safely turn our attention towards the ACL surgery. So again, to bring the knee now in a 90-degree flexion position, we are going to. I've got my knee.
So he's clearing the footprint. He has done the partial medial meniscectomy, or you can say the balancing of the medial meniscus, as well as the lateral meniscus partial meniscectomy from the white zone. And both the meniscus are stable and are in good shape. So there is no plan for any kind of meniscal repair in this case. And now they are proceeding for ACL reconstruction. So initially they have just cleared the femoral footprint of the ACL with RF, and then the tibial footprint is also marked. Okay. And now they are measuring the size of the footprint. Yeah. It's approximately 14 to 16 mm anteroposteriorly, and mediolaterally, if you see, it's about 8. It's about 8 mm. Meanwhile, if you have any question, we can ask. Yes, they have made that medial portal slightly higher and towards the patellar tendon. I think they will make an accessory medial portal for the tunnel separately. Okay. That scale comes with for intraarticular measurements. It's not very large. It is only about a centimeter in diameter or the width, and it's long about 10 to 15 centimeters. What? No, it's 8 millimeters. Yeah. So you can see the posterior margin of intermeniscal ligament, and anterior to that is the footprint. Okay. This, yeah. So this is a needle which is coming from accessory medial portal, which is far medial and inferior, just above the medial meniscus, and it will give a good trajectory for the femoral tunnel placement. And you should be very careful while you make this portal, and you should make it horizontal, because if you make it vertical, you can hydrogenically cut the middle meniscus also. So it should be a horizontal portal and just above the middle meniscus. And now with the straight artery forceps or hemostat, you just dilating the portal. once again probing and confirming the location of femoral footprint or the isometric point. Yeah. Yeah. So this is this is viewing from the high and AM portal. Yeah, and the scale is now placed from the anterolateral, high anterolateral portal. Okay, so the center of footprint can be identified, and now this needle is going through the accessory anteromedial portal. So at present, all the three portals are being used. One for the scope, high anteromedial portal, accessory medial portal for the making of tunnel, and anterolateral portal for putting a scale or measurement. Okay, so this was a chondral pick, or you can say microfracture all, through which they will make a isometric point on the medial wall of the lateral femoral condyle. Signals are lost from OT.
So this is exactly 7 millimeters.
So again we are now. So this we are able to see the isometric point. Yeah. Hello.
ऑडियो नाही जाते आपला त्याला सांगायला लागते तिकडनं.
So
हॉल में पूछो ना कि ऑडियो जा रहा है कि नहीं जा रहा है.
आ रहे आप
अरे आपको जो आदमी उधर उनको पूछो ना हॉल में ऑडियो सुनाई दे रहा है.
Now your audio is being heard.
Yeah. So hello.
Yes, please go ahead.
Hello.
Yes, sir.
Yeah. So there are three ways in which you can select where your footprint where you will drill your femoral tunnel. First is that you can use landmarks. For example, if you have a very prominent ridge, you can use those ridges to understand and find out. Second is that you can use the ruler method, which I just showed. So in this case, the femoral footprint was measuring approximately 13 millimeters from superficial to deep, and I marked it out at the 6 millimeter point. So you want to be slightly more deep towards the AM side. Is that you can use set guides which can allow you to and are available in variety of lengths 3, 4, 5, 6. So you can use something like this. This is a 6.5 offset guide, which is slightly more than what I want. So this is the other thing you can use. So I don't really like offset guides because offset guides are very generic, in the sense that they will force you to put it in that particular place or position. This is a 5.5. I'm sure maybe a 5.56 is what we have done. Yes, and that goes in well. So we were 6 millimeters from the back of the knee, which is where we want. And now I'm going to flex the knee and bring. We have a 5-strand graft that millimeters in diameter, which is exactly what. And now I bring in I've cannulated. I just prefer this type of an arrangement where I just go in through and through with a 4-5 type of a drill bit, which I find is suitable and makes life very easy. We want to go ahead and measure the length of the. Usually in an adult, it will be 38 millimeters for an adult. What we have 34 millimeters. Rigid loop for 20, and then we will go ahead and drill the femoral tunnel. I put in a nitinol guide wire which you get from the screw because this allows me 90. The medial femoral condyle is very close to trajectory. Of the medial femoral condyle. So use a guide wire which comes with the screw, and with hand, 1 second, Anshu, with hand, you towards Siddhartha, please. You now guide it towards the area of the femoral tunnel, hyperflex, and now you start properly. You want to drill to a total length of around 30. At palpating the cortex, I know that it is correct, and then I will slowly bring it out. Reverse मध्ये येते का बाहेर?
Is there any specific reason for using nitrilon wire instead of any hard rigid guide wire?
For iatrogenic injury to the medial femoral condyle. So by doing that, I MFC issue a flex. ये क्या चल रहा है अली भाई आपका कम नीचे कर रहे हैं. If you use flexible drill bits, they also do the, but we organize or we conduct ourselves with this particular. We've looked femoral tunnel. Once we, I'm just clean up. And do not forget to look at your femoral tunnel by putting your scope through the anteromedial portal and looking at how you ensure that there is out, no lateral blowout, and no posterior blowout, and your femoral tunnel is looking exactly where you would want it to be. Ruler देना अंशु please. Ruler दे दो, arthroscopic ruler आपने. And again, you confirm with your arthroscopic ruler that it is exactly of your femoral footprint as it should be. We're now bringing the key. Start off by performing the tibial tunnel. In the tibial tunnel, we're going to be now looking at cleaning up a bit, preserve as much remnant. Preserving all the remnant at the cost of correct tunnel position. So, what's the next? Okay. Okay. So, footprint. So the best. Here, you can use the anterior horn of the lateral meniscus, which is right there, and you can follow the posterior border, and the posterior border will take you exactly to where you want your tibial footprint or your tibial tunnel to come out. So here's coming in with a radio frequency device, and with the radio frequency device, we will now make a mark as to this is where I probably want it to be, and again you can elbow there, elbow. and then we'll go ahead and we'll do the necessary drilling. So you have two types of devices. You can have a tip or you can have an elbow device. Mind you, the elbow device, the wire comes off at the level of the laser mark. So here we have looked at the laser mark, which is right there. And I am now going to use a bead pin to drill the same log jala. So now we've locked the jig. There is no specific angle with which you set the jig. I normally set it at around 50 to 60 degrees of knee flexion. Longer the graft, longer should be the angle so that you get a longer tunnel. Shorter the graft, shorter should be the angle so that you get a shorter tunnel. Now you've got your guide wire in, you now have to figure out whether this is the correct position or whether you want this position to be changed or to be manipulated. So if you're now taking out the bullet, the first thing that I want to check is I will bring the knee to full extension with the bead pin in place, and I can see that there is no impingement whatsoever. I could move it a bit posterior if I wanted to. That is the other option that I have, but definitely I'm not going to move it anterior. Because she has got hyperextension, I will prefer a slightly posterior position of the tunnel. If you leave it more anterior, the chances of her getting a rupture of the graft because of anterior impingement become high. So we're going to do sequential reaming always, always, and always. Do not do sequential reaming, because sequential reaming is going to allow you to achieve the exact position. That is one. You can do fine tuning and changing of the same. And the second thing that it does is that it prevents blowout. If you use a very large drill and you start drilling in very fast, then you can explode the two tibial spines. So now I can shift it more posterior and I can shift it posterior, anterior, lateral, or medial. I want to shift it more posterior. So I'm going to hold the wire towards the posterior aspect of this tibial tunnel and then drill very slowly, very carefully for it to come out from the back side. As you look at the mouth, coming here, you have to come extremely slow so that you don't remove any bone inadvertently. Now that you've finished sorting out the tibial tunnel, you want to go ahead and clean the mouth. This cleaning of the mouth is important because if you leave behind any bone pieces or if you leave behind bone debris at the level of the mouth, then that leads, there's a very high chance that it could result in a cyclops type of a lesion. So again, cleaning up and ensuring that you do not have any abnormal tissue which is interposed in the front of the knee joint is absolutely essential. I would now want to then shift my scope to a high antemedial viewing portal. We want to again confirm whether we are anatomic in location, both on the tibial side as well as the femoral side. I'm pretty satisfied with my tibial tunnel, which is looking exactly in the center of the footprint and which is looking a bit rectangular as well, since we have used sequential reaming. And now I can hyperflex the knee and get my bead pin in place. So Anshu will now put the bead pin through the accessory medial portal through which we have drilled, and we will bring this out of the lateral side of the knee joint. Anshu, you've got it? Yeah. Now we hold a passing suture in between, and now I'm going to bring the knee back to 90 degrees of knee flexion, which will then allow us to then go ahead and pass the graft. So we now come in with a suture retrieving device. This suture retrieving device is passed through the tibial tunnel, and I'm pulling out the suture from the same. At this juncture, I have switched off any form of irrigation so that you have a dry knee and there's no excessive water that is spilling all over you. The graft has been prepared and is ready on the back table. We've prepared a 5-strand graft using a 20 fixed loop button, and this has been put in a vancomycin wrap. So it's been sitting inside a vancomycin wrap for the last 15-20 minutes, which is what we want. We will load the sutures. The white is the pulling suture, the green is the flipping suture, and then we will try and ensure that the graft does not contact the skin at any moment as it goes inside. We'll now start the inflow again. You want to ensure that when your graft goes in, your white suture or the pulling suture is the one which is leading. Yes, and gradually bring the graft in place. At this particular instance, we want to ensure camera 2, Alibai camera 2. We want to ensure that the passage of the graft intra-articular is completely smooth. And for this, use a bandage of some sort, and then slowly with your knuckles, you will pull the graft in. Inside image large, outside image small. Inside image large, outside image small. Inside image, okay. And as the graft gets pulled in, you want to do a very controlled pulling of the graft in this particular fashion here. And you will now flip it with the help of your green suture. So what I have now is that I have flipped the graft on the lateral side. I am trying to look at the flip. Sometimes you find that it does not flip in properly. And in that juncture, just using a bit of leverage with your the bandage on the lateral side and using your knuckles can help you provide that leverage. So outside view, camera 1, outside view. I am able to flip the fixed loop very effectively in this particular fashion. And I will now give a nice firm tug on the graft. Inside view large, outside view small. Inside view large, outside view small. Inside view large, outside view small. Okay, there we go. And I will slowly bring the knee to full extension. As I bring the knee to extension, I want to see whether there is any impingement. There is no impingement. The knee is hyperextended at this particular juncture now, and there is no impingement whatsoever, which is what I desire. There is some impingement with the lateral tibial, with the lateral femoral condyle. I think I am not going to do a notchplasty for the same. Now, I probably will not fix the ACL tibial tunnel because we want to perform an extra-articular tenodesis. So we will now proceed to performing the extra-articular tenodesis for the same. Outside view, camera 1. Outside view, camera 1 only. Now we are looking at the lateral aspect of the knee joint, which is right in front of you. I have marked out the Gerdy's tubercle. We will take a 15-number blade, and with the help of a 15-number blade, we will be performing an incision which is based on the Gerdy's tubercle and is extending proximally for a distance of approximately 7 to 10 centimeters in length. We dissect sharply through the subacute fascia and the subacute fat to expose the tooth forceps or dissecting scissor. Dissecting scissor to expose the iliotibial band. So what we have here is now we are opening up the subacute fascia right there, and we want to expose the iliotibial band, which you can see right in front of you. This is your iliotibial band that you see exactly in front of you. Number 2 orthocord guntaka, please. And now you want to use your landmarks. So what are the landmarks that you're going to use? you will now see the Gerdy's tubercle, which is right here in front of you there. I will now use a 15 blade. Okay, let's nikal ke rakhna, please. Just expose more so that you can see better. So this is your Gerdy's tubercle, which you see right in front of you. You want to take a strip, which is approximately 8 millimeters in width. I will use a ruler and I will show you the same. But I think having done it so many times, you just know that it is 8 millimeters in width, which you see right there. And now we will take this strip. Track kara, please. And now you will start releasing this off the Gerdy's tubercle in this particular fashion here. So release from the Gerdy's tubercle the strip, which is approximately about 8 millimeters in width. Do sharp dissection so that you can get all the insertional fibers of the iliotibial band, and then this will allow you to then create a strip which is based proximally, or sorry, which is based distally, which you will use for your extra-articular tenodesis. Slowly, Anshu. This is my strip for the Gerdy's tubercle, which is the iliotibial band, dissecting scissor. Got it? Okay. And this should be extended proximally for a distance of approximately about 8 to 10 centimeters. Right. दिख रहा है ना सर Ali bhai? I'll take a suture. Suture देना बेटा. कौन सा भी देना जल्दी फटाफट. कुछ फर्क नहीं पड़ता. कौन सा भी दे suture जल्दी दे यार. फास्ट दे. Blue लगा के रखा है ना सर ने किधर पे भी. कहाँ पर है? हाँ. So we're just taking a small stay stitch here at this juncture. This stay stitch is going to help us manipulate the suture underneath the FCL, and we will be then using it to help with fixation at the Gerdy's tubercle. So this is your strip of the iliotibial band. And now with this sorted out, we want to now move our attention towards identification of the fibular collateral ligament. The fibular collateral ligament will be identified by palpating the tip of the fibula. And you can feel the cord like FCL move proximally from the same. This is the tip of the fibula right there, and you want to clear the fascia. हाथ में देते तो अंशु खाली है ना बीच में आ रहे क्या वो सर बीच में आ रहे क्या हाथ नहीं ना बोल दीजिए अगर आया तो
No. We are able to see.
Yeah, and now you want to identify the FCL. This is the FCL that is coming into view. So you can take a moment, you can feel the tip of the fibula, and as you roll your finger, बेटा यहाँ पे ध्यान रख उधर क्या है उधर कुछ नहीं है ना इधर देखो आप. As you roll your finger, you can feel a tight cord-like structure, which is nothing but the fibular collateral ligament. You will have two layers of synovium. Sorry, you will have two layers of fascia, which are reflections of the synovial layer, which are at this junction. They form the bursa, which prevents any form of ITB friction. And this is the bursa that you need to excise if you have a patient who complains of frictional ITB tendinitis or tendinopathy. I would now then proceed to use my 15 blade and make an incision in front. I would use my 15 blade to make an incision in front of the FCL and behind the FCL just to open up the bursa. Very frequently, when you go ahead, the inflated joint capsule is extremely close and you may end up sort of, making a small synovial rent which drains the fluid. But it really doesn't matter if that happens because it is not a big deal at all. So what you see here now is the FCL, which I have identified and have passed my dissecting scissor below the same. You have to go underneath the FCL if your tenodesis has to work. So if you're doing a modified lamare, then you will keep the insertion of this ITB strip intact on the Gertie and release it proximally. On the other hand, we are doing exactly the reverse. We are releasing it distally and keeping it intact proximally. So what So this is what you need to see. You need to see that your strip of the Gerties, so your strip of the iliotibial band is passing underneath the FCL. And now you will do a tenodesis at the level of the Gerties tubercle from the area which you have released it from by using a simple suture anchor. So we'll now use a titanium type of a suture anchor. I'll just drill a small pilot hole. And then we'll use a titanium suture anchor, which is the Fastin 2. Which is a Fastin 2 type of suture anchor. And I will insert it in the tip of the Gerties tubercle. We want this to be buried deep inside so that it does not become prominent, and I want the suture threads to be oriented in a anterior-posterior direction. We'll go ahead, and now that the anchor is deployed, remove it, confirm that the anchor has deployed properly, and now you will remove and take out all the 4 needles of this particular anchor, which you will then use to repair the same. So I'm sure how are we doing as regards time? So if hold this. Okay, so very quickly I'll just do a tenodesis and then you can proceed with the next scientific agenda. So we have 2 limbs now, the superior and the inferior limb in this particular fashion. Little older the chota, fast mein karne ka abhi sab. And we'll take a couple of sutures and then we'll tie them down with the knee in around 50 or 60 degrees of knee flexion. So again, ensuring that I am taking a decent bite, because the last thing you otherwise want is that you get a cutout. So below to top with the stripe, and again deep to superficial with the other stripe in this particular fashion here. Oops, daisy. Yeah, can I have a tooth first? Lomesh, दे दो. अरे वो फोन म्यूट पे रखो कोई तो भी. हाँ. Now the second one. Again.
So, sir, what is the difference between this type of LET and LET in which we separated from the IT band and keeping it attached?
So great question. Both of them do the same thing, which is to cause a restraint in the rotational laxity which is there. But a good friend of mine from Sydney, his name is Brett Frisch. So Brett Frisch and Tom Neri wrote a nice robotic sectioning paper about 2 years ago in GISACOS, and they looked at the influence the type of reconstruction, they compared an ALL type of reconstruction, a modified Lemaire, and a modified Ellison. And they looked at the effect that they had in controlling rotational stability and constraining the lateral compartment. So with respect to, can you leave this? Yeah. With respect to rotational constraint, a modified Lemaire provides the highest degree of restraint of rotation. So if I am looking at a grade 3 explosive pivot, if I'm looking at a revision ACL scenario, then I would probably do a modified Lemaire. The modified Ellison provides a lesser amount of restraint. So patients who have got this type of rotational laxity, which is a grade 2 pivot, and those who are at high risk, I will do a modified Ellison. And the anterolateral or the ALL type of reconstruction provides a paradoxical restraint with the knee, especially in flexion rather than in extension. So the problem with an ALL is that you place it above the fibular collateral ligament, and because you place it above the FCL, the ALL becomes taut as the knee goes into flexion rather than the knee going to extension, which is where you need it. So that is the reason why probably now the ALL proponents are becoming less, and for the ALL, people have started now placing it underneath the FCL than above the FCL, and that has been a shift in their philosophy. So what is the difference between both of them? Well, they both do the same thing. The modified Lemaire and the modified Ellison do the same thing, but the amount of over-constraint that you get with a modified Lemaire is far more than what you get with a modified Ellison. Hence, in patients with a primary ACL pathology or in patients who have a low-grade pivot shift, which is a type 2 pivot shift, I prefer to do a modified Ellison. Okay. So now, once this is done, I'm just going to quickly take some stay sutures through the superior and the inferior leaf of the ITB strip that we have removed, and with this your modified Ellison or your surgical procedure for your anterolateral rotatory instability becomes complete. So one quick suture here, Anshu, please. Yeah. 2 sutures and your procedure is now complete in this particular fashion here. We're of course going to take, we'll just leave it off for the time being. Again, doing the same thing. Hold please. We're closing the rent on we're closing the defect on the lateral side. And this finishes your modified Ellison's type of procedure. Now, what you see here is that outside view, camera 2. So I have not fixed my ACL. My ACL is still free, but now the knee has become completely stable. So yes, the whole thing does work. My latchman is also gone. It is now a grade 1 latchman, but my drawer is completely 0. Now I'll be cycling the knee on the tibial side, cycle it about 20 times so that you take out any creep and you allow for the graft to find a good orientation of its fibers, and then we will go ahead and fix the tibial side. So these are about 20 of them. Camera 2. Camera 2 now, outside view. And the next question is, what diameter, what screwdriver de mala? What diameter graft should we choose? What diameter screw should you use? So use your screwdriver. If it passes, snugly, then you take 1+. And 1+. 10 सांगा त्याला 10 सांगा हा हा if it goes in with great difficulty take the same size and if it goes completely loosely then you take 2 sizes up so here we will yeah so we're going to go one up here I'm going to put my guide wire I'm going to keep the leg in neutral and I'm going to bring it close to full extension about 10 degrees I'm going to pull on the graft with an axial view wo chahiye mujhe and I'm going to give a posterior drawer and we're going to be using Milagro advanced nahi chahiye beta bio screw to put it in दिख रहा है क्या मालिक
No, yes, we cannot see the screw going.
ओके इधर आ जाओ ये कैमरा 1 अरे तो पीड़न क्यों हो रहा है यार हाँ
I think
इधर से आ जाओ
screw is not visible because
इधर से आ जाओ मेरे लेफ्ट से आ जाइए आप
yeah so yeah now we can see it clearly.
Zoom in करो सर
Yeah, we can see it completely.
Okay,
so what was the length of the graft because we cannot see it coming out of the tunnel mouth?
The length of the graft is 83.
Okay, 83.
So I have adjusted the graft, the tibial tunnel length such, bas enough Anshu. I've adjusted the length of the tibial tunnel such that we don't waste graft coming out.
Okay.
Huh? And this is the screw fixation, Nikalo. And then now this is your latchman, which is completely gone. Your knee has got back hyperextension, which is what we wanted. Zoom out karo beta, Ali bhai.
Yes, we can see that.
Huh? Has got hyperextension, has got full flexion. Your latchman is negative, and your pivot has also gone. And I'll quickly put my scope inside just to check that there are no surprises on the inside. This is a habit that you all must develop to observe the graft. Sometimes you can have sense of false security by your clinical exam, but what is awaiting inside for you is a surprise. So that is my graft. And this is what you want to observe, an oblique flat graft which is going from your tibial tunnel to your femoral tunnel. Okay? Any questions? Any questions?
Sorry. Yeah. Any questions from audience? So people want to talk to you directly when you come back because audio is not that great.
Okay.
And Professor Vijayendra is also waiting for his talk.
Thank you.
So we are continuing with the scientific session.
Yeah, I think so. We'll just thank the whole staff of Heritage Hospital, including the brothers, our anesthetist madam, Dr. Tiwari, and Dr. Jhuna for their excellent anesthesia. We'll thank the team from MyTech.
Thank you, Dr. Sachin Tapasvi. Thank you very much.
Thank you so much.
Nice emotion. Thank you.
Audio off kar do mera.
Right. So we all have had a wonderful experience with the surgery. And we will all hound Dr. Tapasvi when he comes here with all your questions. Our next guest, can we get him on the, is Professor Vijayendra Singh. We have coerced him into come today. He is on call in UK at the present moment. He has saved a few lives and is presently waiting for us to join. Professor Vijayendra Singh has been a colleague. He is clinical director of orthopedics in Medway Maritime Hospital. Many of you who would have gone on the IOS UK fellowships would have met him. He is an excellent friend, wonderful leader, and a very, very valuable trainer. Hi, Vijay. So the hall is waiting with apt attention and patience for you. So there you go. It's your dais.
Thank you, Anand. Can you hear me all okay?
Perfect. Better than we could hear from
Thank
a
you.
local hospital.
Anand, thank you for your kind words. I'm grateful for the Indian Arthroscopic Society. Of course, Anand is a dear friend. Grateful. And all the colleagues who are attending the meeting. Hopefully,
Vijay, you there? Hello? Vijay, the connectivity at your end is rubbish, mate. Good, we can see the slides now. उनकी ऑडियो तुमने परमिट की है? हाँ? Vijay, we can't listen to you yet. Vijay, we can't hear you. Talking दिख रहा है. I am. Hello. विजय आवाज नहीं आ रही है. हाँ, आवाज नहीं आ रही है. We can see your slides, but we can't hear you. हाँ? Please start again. Yeah. Yeah, now we can see you. वो करेंगे ना, थोड़े से होशियार किस्म के आदमी ही कर लेंगे मेरे ख्याल से. हाँ? हाँ. बटन दबाने. हाँ, सब जानते हैं. Vijay, the audio seems to be still not working. We can't hear you as yet.
can you hear me now?
We can, yes, thank you.
Okay. So, and the slide is okay. So, okay. Apologies for all this technology issues. So I would like to thank Anand for his wonderful words about me. I'm only a humble surgeon doing shoulder surgery. He's a good friend and I often come to Raipur. I've met a few of you. I'm going to talk about the shoulder arthroscopy setup and also if anybody is looking to improve their output and throughput, then this would be a good one. I do have a YouTube channel with a lot of upper limb videos. If you're interested, you can look through there. If we look at the history, it was started, Dr. Berman is credited with undertaking the first shoulder arthroscopy in the 30s, and a few decades later, it was actually used for doing some therapeutic. And since then, it's increased in leaps and bounds. Watanabe is considered to have described the portals and popularized the use of shoulder arthroscopy. Now, if we look at the common indications, and the indications increase as the experience and the usage becomes more, two broad groups is the subacromial space for your decompression and ACJ excision, as well as your rotator cuff problems for repair, balloon interposition, or superior capsular reconstruction. In the glenohumeral joint, say the stabilization and arthroscopic capsular release are the two big ones, and as you gain experience, you can look at doing osteoplasty and capsuloplasty. And now people are venturing into doing an arthroscopic Bankart stabilization as well. Loose bodies, synovectomy, although those are becoming less common. First thing is to look at the position, the beat chair and the lateral position, and they have their proponents and opponents. So the beat chair uses a special device which can go onto the table. These are fairly expensive. They do not need any traction. And certainly I think for Indian setup, this may sort of stop people or discourage people from using it. The advantage supposedly is to do an easier, if you want to do an open procedure, it's easier. But to be honest, having done the other approach for a number of years, I'm not certain that this is any advantage. However, your anesthetist will not be very happy if you do the patient in beat chair. Is the perfusion and keeping the blood pressure and the tube, and more often than not, the patient will have to be intubated if you're doing it on a beat chair position. In the lateral position, you don't need a special positioner, although once you start to do high volume, I would certainly advise to get a traction device. Although when I've done it in India, I've done it putting a skin traction device over an IV line with some fluid bags to provide the weight. It does provide easy access all around the shoulder. And as I said, for the beat chair, some people say it's difficult to do cuff procedures or open procedures. But once you do it regularly, I don't think there is any difference. This is just a summary of the advantages and disadvantages of the beat chair, as well as the lateral position. Now, just to take you through the steps, so this is a patient having a right shoulder arthroscopy. My traction table goes on the opposite side. The arrow is marked, and the arm is abducted about 30 degrees and in forward flexion about 30 degrees with the weight about 10 pounds, but you can alter this depending on the weight of the patient. This is the beat chair position where patient's having a different procedure. And you can see there's this device to hold the arm in place. This requires a disposable component every time you use. Yes, it does reduce the assistance. And if I take the arm out, you can see you can mobilize it nicely and easily. And you can access the shoulder joint all around. Going back to the setup, you obviously need anesthesia. I know there's people who try to do it under just a nerve block, but I would certainly advise a GA and a nerve block, as the anesthetist is able to control the blood pressure quite well. There's nothing more sort of bad than having a blood in the field, and a hypotensive anesthesia is required. A camera stack and fluid management, as well as some instruments which we'll go through. So the standard equipment would be the same as is required for knee arthroscopy. In addition, you need a fluid management pump. Radio frequency probes, I would say, is more regularly used in the shoulder than in the knee arthroscopy. That's a pretty standard stack with a camera. This is the source for the shaver. This is the pump. This is the shaver and a printer attached to it. Now, the fluid management in shoulder is quite important because you can't put a tourniquet on. And there are a variety of pressure pumps that are available that helps keep the operative field clear. You need to distend the joint to reduce the bleeding, clean the debris, and also keep the scope clean. Important is to keep changing the fluid pressure as required. If it bleeds or you can't see, then certainly increasing the fluid pressure will help. The flow of rate needs to be controlled, and you can either use just the shoulder scope with the cannula, or sometimes a separate cannula may be required, and the pressure at which the flow goes. So that's where the pump comes in handy. If you use a cannula, you need to make sure that you have a high flow cannula. And also if you're putting the pressure up, remember that if you put the pressure up, the tissues get used to that pressure, and that high pressure will be reached. So it's only advisable to use high pressure for a short burst. If you're going to start off and do not want to invest in a pump, then a gravity flow works. And again, I have done it personally, both in UK and in India as well. The disadvantage is that it's not as controlled, and as the fluid bag gets empty, the flow will reduce, so you can put a blood pressure cuff on it. If you're using this, the key thing to remember is the hydrostatic pressure is 1 foot of the height gives about 22 millimeters of mercury. And remember, this is not from the ground surface, this is from the level of the shoulder. So you really need to be putting the fluid back at about 8, 9, 10 foot high up into the ceiling if you're going to use that. Or you can use a variety of pumps. There's lots of them that are available in the market, equally good. And I must say in the last 8, 10 years, the quality has definitely improved. So in general, if you're starting to use a shoulder arthroscopy, you need to have these things. Make sure you have high flow cannula, avoid any kings, avoid any punctures into the joint space. And I think this is vital, not just for shoulder, for any arthroscopy, as otherwise fluid does tend to seep out and make the joint swollen quite quickly. Variety of cannula, some disposable, some reusable ones. Some may be available where you can attach your camera and the scope to the same cannula. Different types of instruments that are available, and again, I guess this will be guided by what company's implants you're going to use. And I'm not going to go into any more details because they're there or thereabouts. There's a variation on the theme, whether you've got your lasso, your suture passes, your cannula, and your motorized instruments. Going on to the portals remain the same, whichever position you do. Basically designed to access most areas of the shoulder. The posterior is the most common, and that's the viewing or the workhorse. The anterior, the anterior superior, and the lateral. These are the common ones, and there are a variety of others. First portal is posterior, which is about 2 centimeters inferior and medial to the posterior tip of the acromion. I always prefer to infiltrate the joint with saline, although there are some proponents who see it to do a dry scope. I personally do not think that changes any management, in my opinion. Palpate the soft spot once the patient is asleep, and then I use a number 11 blade to just make the skin incision. Use a blunt trocar and sheath, keeping the hand horizontal or vertical, depending on which position you are in, pointing towards the coracoid, and you should feel a give. And this is the diagram that is used. So this is the glenoid at the back, and this is your trocar coming along. And then if you can't feel it easily, then you can walk onto the back of the glenoid. And once you find the divot, then you can push through. Remember, you must aim towards anterior superior so that you don't damage the humeral head. Short video demonstrating the same positioning. So this is in a lateral position. That's the posterior corner. And this is the whole of the acromion. That's the anterior acromion. ACJ, and there's a dip. If you can put your finger on your shoulder tip, top of your shoulder, you will feel that, and that's in line with the ACJ. And you can draw a line along 1.5 to 2 centimeters along here. This is where most of your accessory portals for the subacromial space is going to go, and you can make as few or as many as is required. Key with the anterior portal is to mark out the coracoid and not go anywhere close or medial to that, as your neurovascular bundle is quite close by. How do you get other portals? I always use spinal needles, even now, even for a simple decompression, because a few millimeters off the track and it could just make the procedure more difficult. Portals should be as close to 90 as possible to facilitate visualization. They should be small but large enough to let the instruments of the cannula. I don't routinely use cannula unless I'm doing some repair, as suture management becomes easier. And if you're using cannula, beware of the cannula sitting in the soft tissue, as it can cause seeping and make the shoulder swollen. A diagrammatic representation again of the same I've just described. Establishing the portal, the Weisinger technique inside out. This I probably use only for stabilization if it's a big patient, or the outside in, which is using a needle, which is the most common one. So this is a shoulder. Have I lost connection?
No, you are around.
Okay, sorry, yeah. Okay, so
You are around.
this is a shoulder for a stabilization. That's your biceps, and this is your subscap, and this is the rotator interval, viewing from the posterior portal. And what I'm doing is moving the scope above the subscap into the rotator interval and passing it through. And then I put a switching stick, take the scope out. That's what I'm doing now. That's why it's gone blank. And then over the switching stick comes your dilator. So you can see it comes just above the subscapularis tendon there. This way you establish that anterior portal as low as possible, just above the subscapularis. You can then have an anterior mid-glenoid portal, and you can have low and lateral portal. As anterior superior is for using for viewing the anterior glenoid for your slap and your labral repairs, and also for your ACJ excision. So if you got to go into the subacromial space, as I showed on that video and the diagram, it's roughly about 2 centimeters below the lateral edge of the acromion. Common is junction of anterior third and posterior 2/3 to do your decompression, as well as for cuff repair. So this is just showing a quick diagnostic normal shoulder arthroscopy. This is the glenoid, this is the left shoulder, anterior labrum, looking for any tears. And there's a soft spot in the glenoid, which is more or less center and can be used to measure the anterior bony defect. This is looking for the biceps at the top, looking for your slap lesions. This is at the top of the biceps. And then you can flick around the probe from the top of the biceps to assess for any instability or any tears in the groove. This is in the subacromial space now, so you can see the needle is passed. This is a normal looking subacromial space. This is a nice, shiny and smooth bursa. Acromial ligament, the silver shiny stuff around the front, this bit. And at the bottom is a rotator cuff. This video was just taken for diagnostic purposes. And this is a patient who has got some subacromial impingement. You can see there's some fraying of the bursa, both sides, both the acromial and on the bursal side. There's fraying under the undersurface of the acromion. So in summary, I would certainly advise and encourage that you go and see both the positions, the beacher and the lateral position, and see whichever suits your style. Understand your stack system. Learn how to use the fluid management system and familiarize yourself with the instruments. Place the portals when you need them and ask for help if required. Thank you, Anand, and everybody at the IAS. Again, if you want to look at any videos, it's on my YouTube channel. Thank you.
Many thanks, Vijay. Comprehensive and relatable and understandable and encouraging as well. Thanks a lot. You can
Thank
get
you.
back to saving lives. Bye.
Thank you.
Right. So is it coffee time or are we going to the next one?
So that brings us to the end of this very interesting session, and I thank Dr. Anand and Dr. Tantove for having chaired this session so efficiently. And I request Dr. Manish Budhia to please give a floral welcome to our chairpersons, Dr. Tantove and Dr. Anand Joshi. Now we have got a very interesting session. Now we move on to another very interesting session, that is the slippery wicket, and I request chairpersons Dr. Sandeep Birares and Dr. Shailendra Upadhyay to please conduct this session. Dr. Birares and Dr. Shailendra Upadhyay to please chair this session.
So let me invite Dr. Abhishek Gadge to deliver his talk on ACL avulsion fracture management.
So good afternoon, all of you. ACL avulsion fracture management, also known as the avulsion fracture of ACL from its attachment on the tibial footprint, the tibial eminence. A little bit about the relevant anatomy. Tibial eminence is the elevated region of bone between the medial